Good morning, everyone. It's my pleasure to open this Next Generation Eus course with my co-director, Matteo Tacelli. I want to invite you to get the Wi-Fi password if you want, so you can be connected all the time, and you can download the app. The app, you can find the link at the registration center where you can first participate to the instant poll. There will be questions online, and you can send questions through the app to the moderators. And of course, you can also ask questions here in the room. We really want this to be very interactive, so please participate. We are very excited for today.
So, let's start, and as you can see, I'm not going to start with my presentation because we have, of course, technical issues, and this is normal when you perform a course like this. And so, we pass to the presentation of Dario Ligresti, and I want to, and I'm very excited to introduce him because he's a great doctor, and he's a friend, and he's the guy who taught me the endoscopy, so I'm very proud that he's here with us. And so Dario is going to present us the anatomy of liver segments, and then we have also a presentation on the mediastinum. So Dario, please, the stage is yours.
Yes. Okay, good morning, everybody. Welcome to the second edition of Next Generation Eus. Thank you, Matteo, for your very kind presentation, and to Livia as well for the invitation. So, we will start, it would have been perfect to start with pancreatic biliary anatomy, that is our probably core of our daily activity, but it is also important to talk about mediastinum and liver segment for the reason that I will tell you in a while. So, first part of the presentation will be about linear US anatomy of liver segments, and we will move on with mediastinum later on. I will give you some bites of topographic anatomy as a start, then we will talk about US anatomy and delineation technique, and to test your concentration in this 50 minutes talk, it is quite a long one. There will be some quiz time for you to answer just a couple of questions. So, according to Quinault classification, the liver can be divided into 8 segments. The middle hepatic vein divides the liver into a left lobe and a right lobe. The falciform ligament, together with the left hepatic vein, further divides the left lobe into a left medial sector with 4 segments, and a left lateral segment to segment 2 and segment 3. The right hepatic vein divides the right lobe in anterior segment, anterior sector with the 5th and 8th segment, and the posterior sector of the comprising the 6th and 7th segment. So as soon as we get down with the scope at a gastroesophageal junction, the transducer is naturally faced ventrally, looking at the left side of the liver. And if you imagine 2 arrows coming out from the bottoms of your scope, those are directed towards the feet of the patient. If we imagine to cut the liver in this yellow scanning plane, we can start to study segment 1, segment 2, and looking at the left hepatic vein, middle hepatic vein, and some part of 7, 8. And if we go farther with the scope down in the stomach with a different, deeper scanning plane highlighted in yellow, we can also start study the bottom part of the segment 4 and the segment 3. So don't feel, I mean, it sounds difficult, but I will try to give you some bites, practical bites, to make it more practical. Just let me to focus on a couple of structures that are very important landmarks for subsequent US delineation. So as you remember from the fetal circulation, an important part of, of liver is the umbilical part of the left portal vein, where the umbilical vein join the left portal vein. And this is also visible in the adult, as highlighted in yellow. From this part, the umbilical part of the left portal vein, you will be able to follow the ligamentum venosus. This is a remnant of the ductum venosum that used to be a portosystemic shunt in the fetal circulation. And we will be able to follow that from the umbilical part of the left portal vein to the IVC. A second landmark that is crucial is a ligamentum teres, that is a remnant of the umbilical vein that obliterates and can be followed from the umbilical part to the anterior aspect of the liver, also known as round ligaments. As you can see here, the ligamentum venosum can be followed from the umbilical part, from below, from the lower surface of the liver to the IVC upwards. And ligamentum teres connects the umbilical part of the left portal vein on the lower surface of the liver anteriorly. And it will join the falciform ligament from the front. So starting to talk about US delineation technique, from the gastroesophageal junction, you can immediately scope the left liver lobe with the segment 2 closer to the transducer and the segment 3 below. As you can see here, we can see the left hepatic vein that is dividing the two lobes and can be easily recognized by its triphasic wave, as highlighted by the Doppler. This is the segmental branch of the portal vein of segment 2 with its typical monophasic wave. And as you can see in the cartoon down here, second segment is closer to the transducer, and the third segment can be seen below. Here comes the umbilical portion of the left portal vein, where the segmental ducts of P2 and P3 converge by torquing clockwise the instrument. So S3 comes to be closer to the transducer. Ligamentum teres is coming into view, connecting the umbilical part of the portal vein and going down on the liver and joining anteriorly the falciform ligament. Here we can see the segment 4, the lower part of segment 4, segment 4B, and here again is the umbilical part of the left portal vein. So if we keep on following the umbilical part of left portal vein by withdrawing a little bit the scope, we can go upwards a little bit until this is the umbilical part of the left portal vein, and it can be followed until it connects with the ligamentum venosum, that is this bright ligament connecting umbilical part with IVC, as you can also see here. So this is a crucial scanning plane, because from here you can also see the middle hepatic vein. So that's the point. So we have the ligamentum venosum that is dividing the caudate lobe that is closer to the transducer. This is the ligamentum venosum that not in every patient is so well visible. So in this case I've highlighted with this dotted line. And this is a division plane between the S1 and S4. Here is the middle hepatic vein that is dividing the segment 4A and segment 8. We can only see the upper part of the 8 segment from this scanning plane. If we draw further the scope, we can also image the right hepatic vein. If the video. Yes. So here you can see quite an iconic view, because the right hepatic vein has quite a broad join with the IVC. And here's the segment 1 close to the transducer. IVCs dividing that from S8, as you can see in this picture, and down on the right side, right bottom side part of the screen, we can see the segment 7 divided by segment 8 by the right hepatic vein. The hepatic hilum is a very common scanning plane that we use to imagine when we need to look for the CBD, for example. And the way to correctly trace the way up to the hepatic hilum is to start again from the umbilical portion of the left portal vein that can be followed by withdrawing the scope until the umbilical portion of the left portal vein becomes the left portal vein. That with a counterclockwise rotation gets into the main portal vein and right portal vein with the S4 closer to the transducer and S5 down here. Here you can also appreciate the right hepatic artery that goes together with the right portal vein that from this scanning view goes down. This is the P4, the segmental portal branch of the portal vein that goes to the segment 4, and this is the iconic view of the common hepatic artery, middle portal vein in between, and common bile duct below. Also, the gallbladder is quite a common moment of our daily US delineation, and as you can see in the picture, the scope is looking at the gallbladder from above. So what you see is the gallbladder first, with the fundus on the left side and the neck on the right side from the stomach. Here is the segment 5 that is below, just because we are looking at the gallbladder from above. And this is important to remember when we compare this image to the duodenal scanning plane. Now, let's move to the right liver. That is maybe a little bit less usual for us to scope in our everyday clinical practice, but it's very, very important. As you can see here, those imaginary arrows now are facing the head of the patients, and the scope has a long position looking at the hepatic hilum from above, like those guys are doing while working, you know, on this car from below. So as a result, we have an upside down picture and mirrored right-left. So if you remember what we have seen from the stomach, we have the common hepatic artery closer to the transducer, liver is on the right, portal vein is in the middle, and CBD is down here. But what we see from the duodenal bulb is mirrored. So we have liver on the left, CBD is closer to the transducer, portal vein remains in the middle, and the hepatic artery below. So endoscopically, we need to just pass the pylorus and face the transducer against the posterior wall of the duodenal bulb. First landmark is the portal vein, as we do with pancreatic anatomy delineation. Here's the head of the pancreas, and we can follow back the portal vein back to the hilum. Here's the common hepatic artery. That is an important landmark because we can be sure that we are looking at a portal vein, because here, by torquing counterclockwise, we can study its division into the proper hepatic artery going up to the liver and the gastroduodenal artery going on the right of the screen. We can follow the main portal vein dividing at the portal confluence. So here we can see the right portal vein that can be followed with a counterclockwise rotation. It is close to the transducer, and we can see S5 again closer to the transducer. From here, with moving the little wheel, we can see the division into the anterior branch and posterior branch of the right portal vein with the segments, with the related segments, and we can further follow the division of the anterior branch of the right portal vein into subsequent. Here again is the anterior right portal vein branch serving segment 5 and 8, and this is the subsequent division into P5 and P8 for the 5th and 8th segment. here we can follow them back with a clockwise rotation down back to the hilum of the liver, where we'll see the left portal vein going down on the bottom part of the screen, and the right portal vein staying close to the transducer. Here, the only segment that was missing in the previous delineation was the segment 6, and this is important to follow the right renal artery to get into the kidney. That is an important landmark to locate the 6th segment. This is the right renal artery that crosses from behind the IVC, as you can see in the EUS image. And if you go for a counterclockwise rotation, the right kidney is coming into view, and what you will find if you slightly withdraw the scope a little bit is the segment 6 right above the right kidney. Gallbladder can be imaged again from a different perspective from the duodenal bulb, and again we have a mirrored image, because here gallbladder shows up with the fundus on the right part of the screen and the neck on the left side on the screen, and the segment 4 is below the gallbladder. This is because we are looking at the gallbladder from below. So what we see is the gallbladder first, and then the S4 that is right below. So why EUS anatomy of the liver is important? Because as you all know, endopathology is quite an emerging field and has a very bright future ahead. And so anatomy is crucial to go for EUS FMB or radiofrequency ablation of focal liver lesions. And it is important also for EUS parenchymal liver biopsy. It is important for the portosystemic pressure gradient measurement rather than for the shear wave elastography that is starting to be used to evaluate fibrosis, especially in those very obese patients with some problems with transabdominal ultrasound. And there are also some fields that quite, let's say, experimental, like EUS portosystemic shunt, that it's willing to be an alternative to the TIPS maybe, or again, maybe we can start to think about intralesional chemotherapy or other emerging fields of endopathology. So anatomy is the access point for interventions. So to show you how important it is in our daily clinical practice, let me present to you the case of this 62-year-old man who underwent in 2004 to distal splenopancreatectomy for a non-functioning neuroendocrine tumor that was okay until 2020, when during his regular imaging follow-up, a solid hyper-enhancing lesion came out exactly at the bifurcation of the right portal vein into its posterior branch and anterior branch. You can see anatomic relations is quite close to the liver capsule, and the PV right branch shows some sort of thrombosis that's not so visible in this picture actually. So we needed to get a biopsy of that, but the transabdominal ultrasound showed some very deep location down here and some intervening vessels. So the alternative option was the endoscopic ultrasound. We went for contrast-enhanced evaluation with SonoView, and as you can see here, we can appreciate quite a hyper-enhancement with a diffuse and inhomogeneous pattern. And here is the B-mode imaging of this hyperechoic solid round lesion. So this is the quiz time. Are you know, everybody's still awake? So it's a good starting point. So what I ask you is, from which station are we performing EUS? So I remind you that we are looking at a 6-7 segment. So is it the G junction, the duodenal bulb, or we are scoping from the gastric body? So who is for the G junction? Please raise your hand. Nobody. Who's for duodenal bulb? Please raise your hand. Quite a majority till now. And gastric body was for that? Nobody. So you get, what do they win, Livia, if they're right?
Nothing, but I'd like to highlight that there is the instant poll. I don't know, they do have the questions on here.
Can they use it already for?
Yeah.
Wow,
Yeah.
great. So what we, yeah, so you guys, 90% was right. So this is in real time upload is, you know, that's good to know. Okay, so can we go back to presentation? All right. So now let's identify the vascular structures. I want to know from you what's in A. Is this the main portal vein? Is this the right anterior PV branch or the right PV? So can they vote by the app right now? Are you ready for that? Okay, so let's vote. I give you 10 seconds. Is that enough? Give you 5 seconds more. And the right answer is, that is the right portal vein. Right, you did not so well like previously, because the right answer was the, slow down a little bit because I'm getting confused. All right, so it was the right portal vein. Right portal vein. And I can confirm that because look at that. This is the portal vein at the hepatic hilum. We can follow that with a counterclockwise rotation. This is the left portal vein going down to the bottom part of the screen. This is the right portal vein. And we can further follow that into the liver by a further counterclockwise rotation until the lesion appears. And there is a perfect correspondence with the MRI image. So there is not so much suspense anymore for what is in B, because I can already tell you that that is the posterior branch of the portal vein, as we have seen before, because the posterior branch of the portal vein is going away from us. So we're looking at the liver from below, and the posterior segment runs away from the transducer, so it goes down to the bottom part of the liver. And what's in C? Is the posterior, is not anymore, is the anterior. I spoiled that. So again, there is a perfect correspondence with the MRI image. And just to recap about it, the right anterior portal vein goes along the surface of the transducer and stays always close to the transducer. So if they ask me to give you some tips and tricks, and the first one is a very basic one: be always aware of hiatal hernia, because it's the most common, tricky point for the risk of perforation. Of course, deflate the stomach, otherwise you will see everything quite blurry. And from the bulb, a good tip is to think about withdrawing the scope against the pylorus to be able to fully interrogate the right liver, because if you don't do that, you will always miss the upper part of the right liver. So pull the scope against the pylorus, being carefully not to slip back in the stomach. And this is quite, when I learned about liver anatomy, it sounded strange to me initially, because nobody is, I'm sure, that is using the small wheel during the US, your daily US practice, but the small wheel is fundamental to see the division of the right portal vein into the posterior and anterior branch. As soon as you see the right portal vein and you move the little wheel, it divides, so keep it in mind. Another advice is to always review the imaging that you have available, because, for example, liver cysts are so common. So if you know that that patient has got a liver cyst in the fifth segment, you will spend some time to look for that, and you will double check somehow what you have learned with some lesion, because sometimes, you know, you look for just for the anatomy, but you don't have any real-time confirmation. So look for benign lesion like angiomas or cyst. It's a very useful way to train yourself. So let's move to the second part of the presentation and talk about all right. Thank you. Warm audience, very warm one. So let's talk about the mediastinum. We can divide mediastinum into three compartments. So we have an anterior mediastinum that is a field of thoracic surgeon. We cannot image by EUS, but what we can do is to look at the middle mediastinum and the posterior mediastinum. This is a very nice picture from a friend, from Nikhil Santalia from India, and he was thinking to look at the mediastinum from behind, from the esophagus, and these are all the structures you will be available to look at. So we will see the left ventricle, the aorta, the left atrium, and the right atrium. This is the azygos vein on the right side of the body. We will talk about it in a while. The superior vena cava, that is another very important landmark. The trachea, you cannot see the trachea because it's filled of air, of course, but this is an indirect landmark. By seeing the air, you will orientate somehow. I will show you. And you can also very precisely look at the supra-aortic trunks, as we will see in a while. So let's start with the heart anatomy. We will start from the liver, again, looking for the IVC coming out from the liver. So the IVC here is joining the right atrium and the superior vena cava. This is a bicaval plane, so we see the right atrium with both vena cava joining into that. Closer to the transducer, we can see the left atrium and the left ventricle divided by the mitral valve, and the pulmonary veins on the right side of the screen joining the left atrium. This is important. We can see also 2 of the 4, of course, pulmonary veins. We can see here the aorta coming out from the left ventricle with the aortic valve. This is the aortic bulb, and below you can see the pulmonary trunk. But here you cannot see the pulmonary trunk coming out from the right ventricle, because the right ventricle, and as you can see here, this is not listed into the landmarks, because the right ventricle, as you can see here, is really far away from your transducer. Is the most anterior part of the heart, so you cannot. Sometimes you can see a very tiny part of a right ventricle with a common trunk of the pulmonary trunk coming out, but it's not that usual. So don't look at the right ventricle, because you will never see that. What you can see is the pulmonary trunk, and the pulmonary trunk can be followed until it divides into its 2 branches, and this will lead us to the subcarinal space, because here's the right pulmonary artery that stands on the right side of the screen, and this is the left atrium on the left part of the screen. Those are the 2 main landmarks to locate the subcarinal space, that it's usually considered this triangular hyperechoic space close to the transducer that we use for pulmonary cancer stadiation, FMB, and we will see often nodes in this station. This station is station 7, is subcarinal space, and you can see the correspondence with the CT scan image. It is just between, this is subcarinal because it's just below the division of the right and left bronchus, and this is the right, this is the right pulmonary artery here and here, and this is the left atrium here and here. So this is the station 7 that our thoracic surgeon very often asks us to locate and puncture or whatever. Next station is the AP, the aortopulmonary window. And as you can see in the video, you can get into the AP window by slightly withdrawing the scope. This is air into the trachea, and with the 90 degrees counterclockwise rotation, the aorta is coming into view on the right side of the screen. This is the left pulmonary artery, and these two are the landmarks to locate the aortopulmonary windows. It is often that we consider the aortopulmonary window just this triangular section between the LPA and the aorta, but actually this is quite a more complex area because it comprises a lot of nodes. When I started to get into the mediastinum, its anatomy, I was just looking to the four left low paratracheal nodes that are the closest to the transducer, but there are plenty more. We need to pay attention to station 5, that is subaortic, or the para-aortic, that is down the aorta. And this is the left hilar 10L station. Of course, for an endosonographer who's performing transesophageal EUS, you will never go for, get a FMB of station 6 or 10L. This is, they will do through transbronchial EUS, but at least you need to know that they exist, because for stadiation are very, very important when you face with pulmonary cancer, for example. Descending aorta. This is an important station because if you turn clockwise with your scope, the descending aorta will come into view with its mirror image below. And here you can look for the low paraesophageal nodes. It is quite common to find pathologic nodes there again. So this is station 8 that you can fully interrogate by moving forward with the to and fro movement of the scope. And if you are imaging the descending aorta and you turn 180 degrees on one side, on the right side or on the left side, is you to choose. What I do is doing counterclockwise rotation. As soon as you are imaging the aorta, the azygos vein is coming into view. So now we are moving to the right side of the body. This is the first time that we're moving from left to the right. So we are able to look for the azygos area, and going from the top to the bottom, we will be able to study the low right paratracheal nodes and the hilar right nodes all the way through the azygos vein. As I announced it previously, you can have a very detailed image of the supra-aortic trunks, because if you start from the azygos and turn back 190 degrees to the ascending aorta, you will see the left subclavian artery taking off from the aortic arch. And here you can study the upper left paratracheal nodes. The video should play. Yeah. So this is the takeoff of the, we see two structures. Let me go back here 1 second. It should play again. Always the complex slides, always the same story. So this is the carotid artery taking off the aorta, and if you follow that, yes, left carotid again. This is you can see the takeoff from the aortic arch. If you withdraw the scope, this is just to show you that I'm not telling you stories, but it's true. That is the left carotid. Down here, you can image the left internal jugular vein. If you keep on withdrawing the scope a little bit, staying focused on the left internal jugular vein, you will see the left internal jugular vein joining the left brachiocephalic vein and the left subclavian vein. And as you can see from this cartoon here, it's obvious to imagine that the left subclavian vein will go away from you because it's going to the arm. So you will see this, going in the down part, in the lower part of the screen, and you will lose it. You can also see not only the left carotid, but if you torque quite strongly clockwise, you will see another takeoff from the aorta that is, I missed from the video, but anyway, to talk about, that is not just about anatomy, because this joint of this vessel drives you into the 3A prevascular nodes. This is a very another important station for studying the pulmonary cancer. If you get some nodes there, it is already metastatic. It's considered, for chemotherapy. So this is important to look for that. As Mark Giovannini long time ago showed, it is possible to also to image the thyroid gland, because if you follow up to the neck, the left internal carotid that is closer to the transducer, and the left internal jugular vein, you will get into the left thyroid gland. And as soon as you imagine this and you're interested for some reason to the right thyroid gland, you need just to torque 180 degrees clockwise or counterclockwise to image that. So quiz time again, and I will help you from the beginning, because I tell you that we are in the AP window. We are in the AP window where there is quite a tiny lymph node of about 11 millimeters. And we have two structures in the AP window. The one is closer to the transducer, the other one is down here. I will help you again, and I tell you that this one is the aorta, and what I ask you is to locate and identify what's in that. So, what's the structure? I give you 10 seconds again to open the app and vote for the right answer. Matteo, pancreas. This is an option. I forgot to list it. So let's also consider pancreas. Left pulmonary artery. You did very well, because that is you're still voting. Yeah, but more than half. So I feel satisfied with that. That you got the right answer. Yes, that is the left pulmonary artery. A trick that you can use to remember what is left pulmonary artery and what is right pulmonary artery is that the right pulmonary artery stays beside the left atrium. So left atrium, opposite side, the right pulmonary artery. And on the AP window, it's the opposite. So we have the left pulmonary artery close to the aorta. So as I told you, supra-aortic trunks can be really well delineated. And what I ask you is to identify the structure that is the vascular structure that is closer to the transducer. So this is the aorta. I'm helping you again. So if you trace it up to the neck with a slight... Yeah, can you go back just for a while? Can you go back to the option list? Yeah. So you have to choose between subclavian artery, carotid artery, or anonymous trunk. So what is the closest vascular structure taking off from the aorta closer to the transducer? You can vote. Let's say 5 seconds. 10 is too much. Okay. Can you give me the results, please? It's subclavian artery, carotid artery. Subclavian artery is getting points. 2 seconds more. So subclavian artery is getting points, but it's wrong. Can you go back? It is wrong because the closest structure is the carotid artery. When you look at the supra-aortic trunk, so from the takeoffs from the aorta, the closest structure to the transducer is always the carotid artery. So if you go on and you follow a second takeoff from the aorta by applying some upwheel pressure and clockwise, quite a strong clockwise rotation, we will see a second vascular structures taking off. And you can see also a node in between. This is a very tiny lymph node with that is the subclavian artery, correct? I don't know, yeah. And that is the subclavian artery because in order we have transducer, carotid artery, and subclavian artery that stays below, that is always below. Some courageous guy also signed the anonymous trunk. In reality, anonymous trunk is on the right side of the aortic arch, and you will never able to see it. If you do that, report that, it will be published, but as far as I know, it is not possible to see under Eus. Can you go back to the presentation, please? All right. So subclavian, yeah, that is the subclavian artery. So again, why this is important? It's not just a matter of anatomy itself, but it is important. It is important to scope for the mediastinum because some cardiac diseases can be diagnosed incidentally, as this guy of 66 years old who was asymptomatic underwent a follow-up EUS for IPMN, and what we found is that he had chronic aortic dissection that it's really, this is the intimal flap inside the aorta. This is the true lumen with the Doppler signal inside. And this is the false lumen of the aorta as confirmed by the CT scan image down here. So since it takes really 1 or 2 minutes to scope for the mediastinum while you are scoping for different reasons, on the way out it's really easy to have a look to the mediastinum, and cardiovascular diseases are potentially we know that the life-threatening. It's I think it's recommendable to make the mediastinum as a standard part of US examination for gastrointestinal diseases. Many reports are coming out, already came out in the last maybe 10 years, so it is important and think about it. So anatomy, of course, come first, then US anatomy. So it's useless that you are just trying to learn US anatomy. Good advice is to maybe, what I did is to take back the books from university and look for the anatomy that you have to know before to look for the US anatomy, because it will the process, it will be much easier than trying to learn only the black and white images. And what I think is that tracing structures, whatever they are, and identifying the origins is the basis of a good EUS technique. That is the access door. Is the entry towards something that maybe you will do more complex, like interventional EUS, but it will train you to feel haptic sensations and to be very to have the right sensitivity while manipulating the scope. So go for it. And EUS is a bidimensional procedure, so you need to correlate in mind the three-dimensional anatomy, and this really requires quite a continuous training. And what I always like to say when I talk about this stuff is that Professor Dong Wan-so from Seoul, South Korea, that I had the fortune to train with for a while, once told me that he was still learning US anatomy even after 25 or 30 years practice. So, I mean, learning never ends, and we need to, since this is a next generation US course, I think it's useful to think about it. Thank you for your kind and durable attention.
Okay, thank you, Dario, so much for this two wonderful presentation. You can stay there for any possible question. In the meantime, that you think about a possible question, I want to underline a take-home message that Dario told to you, that is that mediastinum is a part of the examination, so as the liver segments. In fact, I remember two cases where the people came for other reasons. I think in one case was an IPMN of the pancreas, and in another case was submucosal lesion of the stomach. And we found in these two cases lymphadenopathies from pulmonary cancers that were not that the patient was not aware about. So take 2 minutes. It doesn't take you so much time. So take 2 minutes and analyze and examine the mediastinum. That is very important. Do you have any question? Cecilia.
Thank you, Dario, because your presentation were absolutely amazing. And I have a question. When you do a of your examination, do you describe even only the left hepatic lobe, or as you show us, we can also see the right part of the right hepatic lobe, and you describe that part, or you just mention the left hepatic lobe in your report?
Thank you, Cecilia. It's up to the time, the available time I have, because of course, as the guys do here in San Raffaele, they always start scoping the patient from the left liver. Am I right? Yes. So the left liver, you know, it's you can do really quickly. So I always report that there are, for example, no lesion on the left liver, because we are able to scope very in detail in and quite a short time. If on the right, I don't routinely report that there are no lesion in the right liver, because it takes time. So my standard report will talk about left liver. If there is any lesion to look for, I will spend some additional amount of time to scope the right liver, but that is not part of a routine US examination to me.
Other questions from the floor? If there are none, I think I'll hand it to my co-director of this course, Matteo Tacelli, who works here, and he will talk about the pancreatobiliary anatomy, US anatomy, if the technology assists us. We'll see.
Okay, while we are waiting for Matteo to start, no, we are ready. Okay, we can go for it.
Okay, maybe we can do it. So, good morning again, and let's start right away with this now the third presentation of this morning session, and this presentation is about pancreatobiliary anatomy in US. And first of all, oh great, it doesn't work. Now yes. Okay, sorry, we have some technical issues, of course. So, I could say that I'm very glad to be here to speak in this congress, congress that we organized. So this is this is something that we chose, And this presentation is very painful for me because the word anatomy alone brought to my mind various terrible memories dating back to my first year in medicine. And when I was in the medical school, and I can assure you that all these memories are bad. And as you can easily see, many things has changed during these years, starting from the amount of my hair. However, one thing has remained absolutely unchanged, the visceral hate towards anatomy. So you are going to have to watch this very boring presentation here early in the morning, and I'm a little bit sorry for you. But we can start with a schematic drawing that summarizes the structures that can be evaluated when performing a biliopancreatic endoscopy. I have to make a small but necessary premise. You won't see any images, any videos in this presentation of the radial echoendoscopy. Also Dario showed to you this. Because despite what the latest guidelines still claim, radial echoendoscopy is an outdated technique to date, and this is even more true in biliopancreatic field, because in that field the probability to perform biopsies is very high. So if you have to learn anatomy and if you have to learn Eus, you have to start with the linear echoendoscopy, and I think it's not useful to learn radial echoendoscopy. So, okay, let's start. To study the biliopancreatic system, we have to perform the examination from 3 stations: the stomach, the duodenal bulb, and the second duodenal portion. Depending on the station that you start the examination from, we have the possibility of identifying and studying different structures, and also portion of structures, of course. So, for example, from the stomach, you are able to see the left liver lobe, the gallbladder, the proximal CBD, the intrahepatic biliary ducts, and you also see the pancreas, but not the whole pancreas, but the neck, the body, the tail. You can see some vascular structures like the splenic portal mesenteric veins, the aorta, the celiac trunk, the mesenteric artery. And you can also see some organs that are in the abdomen, like the left kidney, the left adrenal gland, the spleen. From the duodenal bulb, instead, you can see the left and the right liver lobe, as Dario showed to you, the gallbladder, the CBD, the intrahepatic biliary ducts. We can see the pancreas also from the duodenal bulb, the neck, the head, and the uncinate process. And we can see also the vascular structures that are mentioned here. From the second portion of the duodenum, you can see the neck, the head, and the uncinate process of the pancreas, the CBD, the mesenteric vein and the artery, and the aorta and the cava vein. But we are going to see more in details all the individual stations during this presentation. So let's start by, but before starting from the anatomy of this station, we have to decide from which part of the stomach we have to start the examination. So the first possibility that we have is to start the examination from the gastric antrum and to go to the left liver lobe. And you can see here in this video that we pull the scope back, and by keeping my left arm open, I can look for the liver. Once I look for the liver, I search for the portal vein, and once I found the portal vein, I followed it from outside the liver, and then I reach to the pancreas. In the second case, on the other hand, we start from 40 centimeters from the dental arch with the scope, and from here we perform a counterclockwise rotation, and we look for the aorta. Once we found the aorta, we search for the celiac trunk, we follow the celiac trunk and the splenic artery, and then we reach to the body of the pancreas. Now, this is the celiac trunk. I don't know if you can see it. This is the splenic artery, and on the left, in the centers of the screen, you see the pancreatic body. Okay. Now, we have decided how to start the examination. Now, we have to find the structures from the stomach. So, let's start from the aorta. These are the scans from the stomach, and these are the scans for the aorta. The aorta, as you know, as you may recall probably, once you enter the stomach, you found the celiac trunk and the superior mesenteric artery that arise from the aorta. Above the celiac trunk, there are the celiac ganglion and the celiac plexus, where you can perform the chemical or the thermal neurolysis. And above the celiac plexus, you will find the diaphragm. In that case, it's better not to perform the neurolysis there. And if you follow the celiac trunk, you will find the left gastric artery, the common hepatic artery, and the splenic artery. As we mentioned before, if you follow the splenic artery, you reach the pancreas. What we saw in the previous slide was, of course, a scheme, a drawing. But obviously, we can see it also in US. And you can see very easily in this image, the same structure can be seen in the same way from respect to the drawing with the US. So, this is the scheme that analyze the aorta. You see the aorta there. I don't know if this works. No, neither this. Okay. This is the aorta. This is the celiac trunk. That's the branch on the top of the aorta, the left gastric artery, the splenic artery, and the hepatic artery below. And on the bottom of the aorta, you see the superior mesenteric artery. Okay, now take your phones, it's a quiz time. This is the aorta with its branches that we mentioned earlier. Normally, a structure passes below the superior mesenteric artery, and I help you by telling you that this is a vessel. You can see it in white, the vessel that is below the superior mesenteric artery. So the question is, what is the name of the vessel indicated in the previous slide? Let's go with the vote. It's the left renal vein, the inferior mesenteric artery, the superior mesenteric vein, or the right renal vein. Oh, great. Yeah, I'm not surprised. My questions are very easy. So this is correctly the left renal vein. We can move on to the presentation. Okay. Now, we resume our scan from the stomach, and this time we start from the gastric antrum and we look for the liver. I'm not going to show you the details about the liver because Dario already did it very well and better than me, of course. And however, when we study the liver, the scope is placed at the level of the gastric body with a tip pointing upwards. So the position we maintain is with the left arm open and the big wheel in the up position. And you can see it very well in these pictures, but most of all in this masterpiece of modern art that I did it. Okay. So, once the portal vein has been identified, we must then follow it, and as we saw in one of the previous videos, outside the liver, and then rotate the scope clockwise and gently release the big wheel until we identify the structure of this type. Okay? Do you see this structure? Dario already mentioned it. So the question is, this is very simple. I hope that there will be a 100% of correct answer. What is the structure in the square box? Can we see the votation? Okay, I'm pretty impressed. Okay, you're still voting. Let's move to the presentation. I'm still impressed, and not in a positive way, because this is the hepatic artery, the common hepatic artery, as you can see here. So, once we exit the liver, we encounter the portal triad with the hepatic artery at the top, the portal vein in the middle, and the CBD in the bottom. The CBD was easy because there was no Doppler inside. Okay, then we continue the rotation clockwise to follow the portal vein until we arrive at the trifurcation of the portal vein, and that is the confluence between the splenic vein, the portal vein, and the superior mesenteric vein. Here in the US image you can see it very well, but let's make a diagram to understand it better. The portal vein coming from the liver in downward, the superior mesenteric vein is on the right going to the head of the pancreas, and the splenic vein is on the left going to the tail of the pancreas. Above the confluence we find the proximal body and the neck of the pancreas. In this case, when we arrive at the confluence, the large wheel, the big wheel of the scope, is in the neutral position, fully released. Okay? Now we continue our clockwise rotation. We move towards the body tail of the pancreas. Also in this case, the big wheel is totally released. Following the body of the pancreas, we have to keep the splenic vessels on the left of the screen. You see the splenic artery on the top and the splenic vein below the pancreas. And of course the pancreas is obviously not the only organ that is present inside the abdomen. Then, as we proceed clockwise towards the tail of the pancreas, gently withdrawing the scope, we will first meet the left kidney and then the spleen. You see here. Okay. But between the left kidney, the celiac trunk, and the spleen, we can also easily identify these structures. What is this? Yeah, this is the left adrenal gland with its typical gull wing shape, okay? And finally, the study of the body tail of the pancreas is completed by continuing the clockwise rotation until you reach the spleen. And in this case, the tip of the instrument is in the up position because the spleen is located higher respect to the body of the pancreas, okay? And this is a video that summarizes what we said until now. We are in the liver. That's the portal vein in the center. We follow the portal vein outside the liver. That's the confluence, and we see very well the confluence between the portal vein, the splenic vein, and the superior mesenteric vein. And you have the neck of the pancreas above this confluence with the Wirsung inside in the center. You follow with a clockwise movement the body of the pancreas. You have the left kidney there. That's the tail of the pancreas. You go up with the tip and you find the spleen. Then you gently counterclockwise rotation and you see the left adrenal gland and the left kidney, and then you return to the body of the pancreas and to the confluence. And so that's the complete examination of the body tail of the pancreas. And what we explained in 10 minutes was, as you can see, is an examination of 10 seconds, probably. Okay, now let's move to the duodenal bulb. The tip of the instrument in this case should be placed on the anterior superior wall of the bulb, near to the upper duodenal curve. As you can see in the picture on the right, the instrument in this case is very twisted and look upwards, so it can be easily guessed what can be seen from the scans made from the duodenal bulb, but this is a summarize that we already mentioned before, so you can see very well the biliary system and the liver. So let's proceed, and schematically, therefore, this is the design on the US scan that can be done from the duodenal bulb. First of all, we can see that the portal system and you can see that they are inverted with respect to the stomach, of course. Then we can see the head of the pancreas with the ampulla of water, the main pancreatic duct, and the main bile duct with the right and the left hepatic ducts. In addition, you can see also the gallbladder from the bulb. So this is the typical image you should see when you enter the duodenal bulb. The portal confluence on the right, the CBD at the top, and the head of the pancreas on the left. If we rotate the scope clockwise, we move towards the head of the pancreas and the ampulla. And if, on the other hand, we go counterclockwise, we move towards the liver. As we said, the vessels of the confluence are inverted with respect to the stomach. So on the top, you will see the portal vein, on the right, the splenic vein, and on the left, the superior mesenteric vein. So to summarize the bar scan, if you go clockwise, we can see, we can study the head of the pancreas, the vater ampulla, the dorsal and the ventral pancreatic duct, and the CBD. Otherwise, if we go counterclockwise, however, we study the extrahepatic biliary structures and the biliary system in details with the gallbladder and the liver. And this is a video that summarizes it. Okay, it's moving. That's the confluence. We saw the confluence. That's the liver. That's the hepatic hilum. And you see the common bile duct, the portal vein, the hepatic artery, exactly opposite to respect to the stomach. Then we move clockwise and we see the pancreatic head and the aorta. And then there you see the ampulla, where the common bile duct and the pancreatic duct arrives. Finally, the station of the second duodenal portion remains to be explored. In this case, the instrument is pulled, so it no longer looks upwards, but points directly towards the ampullary side of the duodenum. And in the diagram on the right, we can see a drawing of the US scan from the second duodenal portion. We have the superior mesenteric vessels, the ampulla, the aorta, and the inferior cava vein. And if we move clockwise from the second duodenal portion, after doing the retraction maneuver with the instrument, we see the superior mesenteric vessels, and above this, the head of the pancreas. By turning the instrument clockwise, the ampulla of water will appear with a ventral pancreatic duct, the CBD. We do not take into account the anatomical variation, otherwise this presentation will last 2 hours. And continuing the counterclockwise rotation, we will reveal the aorta and the inferior vena cava. In this way, we are sure to have seen the entire head of the pancreas and not to have overlooked possible neoplasm. Pulling the instrument back and continuing to do these scans between the mesenteric vessels and the aorta, we will arrive at the neck of the pancreas, at which we will identify the pylorus and the gastroduodenal artery. And this is the last video I showed to you. From the second duodenum, you see the duodenal C, the pancreatic head, the distinction between the ventral and the portion
part of the pancreas that has an echo structure different, hypoechoic and hypoechoic. You see the common bile duct. You see, in this case, you see the mesenteric vessel, superior mesenteric artery and superior mesenteric vein. That's the dorsal duct that connect with the pancreatic duct, and we are pulling the scope. That's the CBD. And the pylorus is coming on the left, and the gastroduodenal artery is coming also on the left, and there you arrive to the portal mesenteric confluence, and then you can start again the examination from the stomach, because you are arriving to the stomach. So, we explored the pancreatic anatomy, the biliopancreatic anatomy. It's a very practical presentation. So thank you for your attention, and please, if you have some question, feel free to keep for yourself.
Thank you, Matteo. We're not that late, so that's good. If you have any questions, you can ask them either here on the floor with a microphone or on the app, so please feel free to ask anything. Any questions from the floor?
They did what I asked to. Oh,
okay. Dario, can we have the microphone?
Matteo, balloon, yes or not?
Balloon, yes, definitely. Not because I think that it will protect you from injuries. This is not my goal when I use the balloon. But I think that in some cases, especially in the duodenum, by filling the balloon with water will help you to have a better window to explore the structures. So it can help you. It doesn't cost you so much to put it, and I think it's good to put the balloon.
And do you use water injection into the lumen?
Yes. We use water injection from in the second duodenum, of course, because it helps you to avoid to have air in the duodenal lumen, and to study especially the ampulla is the structure that you have more difficulties to study without the water, because you have a lot of air in that part. In many cases, you have periampullary. I don't remember the name. Diverticula, and so I think that in that case is very useful. And of course, we use the water injection also for the study of the submucosal lesion, and the study of and the staging of gastric cancer, duodenal cancer. So I think that water is very useful in the US.
Cecilia?
So thank you for the lecture. Any tricks to the evaluation of the head of the pancreas when you have an altered anatomy?
Oh, it's a good question, and it depends from the type of surgery that the patient performs. If you have in example, a pancreatic duodenectomy with a pylorus preserving, I think that you can study the head of the pancreas with the remnant head of the pancreas, of course, because you can perform the so-called alpha maneuver, and you can push the scope, you can pull the big wheel in up position, and you can reach to the head and the neck of the pancreas very easily. In cases of other types of surgeries, I think that it depends from patient to patient. I go first, of course, from the stomach, and then I try to explore the various loops to try to find the head of the pancreas. We have to underline that the probability to have a perforation in this patient is very high because the duodenum, the jejunal loop are not the same as the duodenum or the stomach. So, and you are in not canonical position, so you have a great risk of perforations.
Other questions from the floor? Can I ask for tips to study the ampullary region? So you inflated the balloon, you put some water, but then what? Can you examine the ampullary region properly this way, or do you have any other tips and tricks?
Okay, thank you for your question. Okay, the ampullary region is very difficult to be studied because it's a region where you have to go up with a big wheel, and you see very well the ampullary region, but you are not able, in this case, to see the ducts that goes inside the ampulla. So you have to free the big wheel, so in a neutral position. You have to push a little bit the scope to fill the duodenal lumen with water, and of course, you have to turn off the air inflation, because you can have also always some loss of air during your examination. And in that case, you're able to study the ampulla very well, and to study also the ducts that goes inside the ampulla very well. The goal is not to compress too much the ampullary region, otherwise you're not able to study it in a proper way.
Other questions from the floor? Otherwise, I think we can move on to the next session on indications to EUS in debatable diseases. So I'd like to invite the discussants here on the floor, Dr. Stiliano, Della Iglesia Garcia, Dr. Signoretti, Lisotti, and Dr. Tamburrino. We are very happy to have also a surgeon here, because it's always good to have
the best pancreatic surgeon in the world.
Some good contamination from other specialties, which is very, very important.
So, good morning. Thank you, Livia and Matteo, for inviting me. So, let's change topic. Let's talk about the indication to EUS in debatable disease. What about pancreatic cystic lesion? Well, when we have to deal with pancreatic cystic lesion, we are speaking about a very prevalent and very heterogeneous group of lesion, and especially with a very different malignant potential. So the first thing we have to do when we meet a pancreatic cystic lesion is to try to differentiate mucinous from not mucinous cyst. Of course, this differential diagnosis is not so easy. And data from literature has shown that a high rate of patients receiving surgery for pancreatic cystic lesion didn't show malignant potential. And also those cysts that were supposed to be mucin cysts at the final histological diagnosis didn't show any high-grade dysplasia or adenocarcinoma. In another recent study was shown that the preoperative presumption of malignancy was correct only in almost 15% of patients. So it's clear that we have to improve our preoperative assessment of this disease. Well, the US seems to be the perfect, the ideal tool for the evaluation of these lesions. That's thanks to the strict proximity of the transducer to the pancreas, but also because some cystic features are better visualized with the EUS compared with other technical images. For example, the honeycomb pattern, as you can see in the first picture, is better visualized with EUS, and also small mural nodules or the internal structures, the connection with the pancreatic duct. These are all features that are very better seen with the EUS. Well, of course, not all disease needs EUS. Of course, you can see there are some pathognomonic aspect of cystic lesions that give us the chance to recognize, define better these lesions. But when we have to ask help for EUS? Well, in literature, the last years, a lot of guidelines has been published focused on this topic. And so when we have to ask it, with small differences between the years, but all the guidelines has the same mainstay that EUS is not the first line technique we have performed, but it's come into play when there is the suspicions of malignancy or when the diagnosis is not clear. Just a few words in details. According to the European guidelines, EUS is recommended if there are some clinical or radiological features concerning for malignancies. And again, it's confirmed also in the American guidelines, where you can see in this diagram the EUS with or without FNA is not the first line of the management, but just come into play when there are some clinical or radiological signs, suspicions for malignancy, or where the diagnosis is not clear, differential diagnosis between IPMN and mucinosis is not clear. And that is even confirmed in these very new guidelines on the management of IPMN, where again these guidelines recommend that EUS must be performed in case of IPMN with suspicious of high-grade dysplasia or in situ carcinoma. So, however, even this ideal technique has some limits. Of course, first of all, it is an operator-dependent procedure. So the study suggests that it has, for the definition of morphological aspect of disease, it has a poor inter-observer agreement. And also, always the morphological criteria have low sensitivity and specificity in differentiating the different type of cysts. Well, fortunately, we have some tools that can help us to improve the diagnostic yield of this technique, such as the contrast-enhanced EUS, of course, the fine needle aspiration, and the through-the-needle biopsy. What about the contrast-enhanced EUS? Well, guidelines recommend both the European and the American guidelines recommend the use of contrast enhanced, especially if we have to differentiate the nodules, the suspicious of mural nodules. And also it helps to assess the vascularity of the cyst. I would like to show you some results from a recent systematic review and meta-analysis evaluating the role of Eus in the assessment of neural nodules, and it shows how the sensitivity and specificity is high with a poor diagnostic accuracy of almost 96%. For example, in this case, this was a patient with a small cystic lesion that was sent to us after after an MRI showing this neural nodule. I don't know if it's seen. Well, the size was almost 6 millimeters, so we decided to study with after the injection of the Sonoview, and you see after the injection there is no enhancement of the nodule. So we hypothesized that it was a mucin plug, so an IPMN with a mucin plug, and so it's not a worrisome features, and we didn't have to change the management of this cyst and continue just the follow-up. Another nice case, it was a case of a woman with the discovery of a dilation of main pancreatic duct and atrophy of the pancreas. And well, it was sent to us as for a differential diagnosis of between IPMN and chronic pancreatitis. Because she had a history of acute pancreatitis. Well, you can see just with the endoscopic view, we saw this nice typical aspect, fisheye, where you see the mucus from the papilla, and that is pathognomonic for the main duct IPMN. And at the US evaluation, you see a huge dilation of the main pancreatic duct that is higher than 1 centimeter, so it's a high-risk stigmata and very suspicious for malignant potential. And you see inside the duct there is some materials. We tried to inject the contrast enhancement to see if there was some captation, so some neural nodules, but it was no enhancement of the nodules, so it was just material and mucin plug inside the duct. Of course, it didn't change the management because it's a main duct IPMN, so it requires surgery. What about the other tool, the other advantages of US? Of course, the most important features, power of the US is the chance to obtain some of the cystic fluid material. Well, guidelines, of course, says that FNA improved the diagnostic accuracy in differentiating the cystic lesion, but don't do FNA for all the cysts, because data supporting that it should be performed only if the expected results would change the management of the cyst. And that is what the European guideline says. It is confirmed also in the American guidelines, again, when the results change the management of the cyst. And again, in the last guidelines for the IPMN, again, don't do perform it only when the management would change, but more important, first, I think the first time was written especially that the FNA should not be performed when high-risk stigmata is clear at the previous images. And so the surgery will be done regardless of the results. So my experience, a lot of time surgeons ask for us the collection of the fluid to define the malignant potential of this cyst, but it's not correct. You just increase the possible adverse event. If you have some features that are already high-risk stigmata, of course, you don't have to perform it. Well, so we have obtained this fluid. What can we do with it? Of course, we can send it for the cytological evaluation, but data are not so in favor of this because the pulse sensitivity is quite low, even if the specificity is high. The problem, the problem is that there is a low rate of cell exfoliation in the cystic fluid. So papers suggesting that since almost 50% of fluid samples from IPMN are acellular, the absence of atypical cells doesn't exclude malignancy. So always take with conscious these results. Of course, we can dose also some markers. The CL level, high CL level was historically associated with a high probability of mucinous cyst, and it's confirmed also in this recent systematic review and meta-analysis. However, it has still a low pulse sensitivity and specificity of 87%. A new marker that in the last year has been object of a lot of study. You will find a very high level of study in literature showing that glucose had a higher sensitivity and specificity in distinguish mucinous from not mucinous cysts, lower level of glucose. And it's confirmed also in this other systematic review and meta-analysis where the overall diagnostic accuracy was almost 94%. And the advantages of this marker is that it's cheap and it's easy to perform because you can also use the glucometer and those on site directly the glucose level. Another case, this is a woman, 52 years old woman, with during the follow-up for this cystic lesion, 2 centimeters cystic lesion in the body tail of the pancreas, came to us because of there was a change in the size of the an increase in the size of the lesion. Actually, in all the MRI that she performed, a clear connection with the main pancreatic duct wasn't described. So we decided to, it has also a small septum with enhancing. So we decided to perform EUS, and you see in the first image the EUS aspect of the cyst. And inside the cyst there was this nodule. It was about 6 millimeters, quite small nodules. But after the injection of Sonoview, it didn't show any enhancement. So the hypothesis it was that even if it was a kind of mucus, as the example I showed you earlier. Because of there was not clear the diagnosis, so there was no clear connection with the pancreatic duct. There is this increase in size, so we decided to proceed with FNA and aspirate the fluid. And actually, the results was different from what we expected because the syringe size was negative, so there was no the fluid was not mucus, and also the glucose level was higher than 50. That is the cutoff that is used every day. And of course the cytology didn't show any cell. So maybe we can change the original hypothesis of an IPMN, and it could be more a serous cystic lesion, and maybe the material that we saw inside the cyst was like calcification or something else. So maybe it changed, of course, the management of this cyst. The last advantages of this, the EUS is, of course, the introduction of the through the needle biopsy. Well, this small device that consists in a small biopsy that can be introduced in the in a 19-gauge needle have changed the management, I think, for the cystic lesion. Of course, it allowed the obtainment of a small sample fragment of the cystic wall, and so an histological evaluation. Studies have shown it has a high technical success, almost 100% in several study series, and also it has a high diagnostic accuracy rate. Well, it is confirmed also in these other recent meta-analyses showing high technical success and diagnostic yield about 80%. But the important thing, I think it's from this, well, it's a recent paper that, of course, didn't include a huge number of patients. But I think it's interesting because from these results was shown that through the EUS, through the needle biopsy, added diagnostic information in almost 77% of cases, and also it led to change the management in 71% of cases. And I think that's the real important aspect of all this cyst management. I would like to show you a video. You see here the biopsy that is opening inside this huge cyst lesion that was suspected to be mucinous cyst for the history of the female patient and for the history. You see, you should have the advantage is that you can take a small biopsy, and to be sure that you have obtained some materials, you should have to see the 10th sign. I don't know if in the video was clear, but in that way you are sure that you have some materials. And of course you can perform it several times by leaving the needle inside the cyst. And in these patients, the interesting was that the hypothesis was it was mucinous cystadenoma because it was a young female patient, and with this unilocular cyst. But of course, before the patient was hypothesized to be going to surgery, but we prefer to obtain some material before the procedure. So interesting, the fluid analysis show a low CL level and a high glucose level. The cytology again showed no cells, but the histological evaluation described a cubic epithelium without malignant features, and it was suggestive for serious cystadenoma. And of course, the patient didn't receive surgery, and she was really happy. The similar case in this other young female patient, again with this very big cystic lesion, almost 5 centimeter cyst, with a small septum that didn't enhance after the contrast administration injection. And again, even in this case, we decided to perform through the needle biopsy. Of course, this procedure can combine the standard FNA aspiration because, of course, the liquid is aspirate and you can dose the markers and do the cytological analysis. And also, in this case, the fluid was not was transparent. The skin sign was negative, and again the glucose level was high with low CL level. And even in this case, the final histological diagnosis was a serious cystadenoma. And again, we changed the management of the cystic lesion. Another nice case in cystic lesion with thick wall with some nodules with enhancing after the administration of contrast, and we decided to perform through the needle biopsy. In this case, the histological diagnosis, the final histological diagnosis was suggestive for neurocrine tumors. So it was, of course, it was a different type of lesion. Well, so is the through the needle biopsy the perfect tool? Well, even in this case, we have to be careful because data have shown that the overall rate of this technique is about 11%. And we have some independent predictors of adverse event that are the number of biopsy, showing that a higher number of biopsy than 2 is associated with a higher risk of adverse event, but also the diagnosis of IPMN is associated with a higher risk of adverse event. So, in conclusion, we can say that not all the patients with pancreatic cystic lesion deserve EUS, but just for when the diagnosis is doubt and when there is a suspicion for malignancy. Again, if you have high-risk stigmata is clear in previous images, don't need EUS, but just call surgeon. And of course, the EUS has the advantages of having several different tools and markers that could increase the diagnostic yield of EUS, but they are expensive and they are not free of adverse events. So use it when it's really necessary. Thank you.
Okay, thank you, Serena. That was a wonderful presentation. Do you have any question? I have a lot of questions.
Thank you.
So I can start from this one. Do you think that we have always to perform an aspiration of a suspect serous cystoadenoma?
Well, I think in the unilocular unilocular cyst, I think it could be useful to have some sample of this because of sometimes you can misdiagnose with the mucinous cystoadenoma, and of course you have to think about which patient you have, the age of the patient, and of course if it's fit for surgery. I think in the management of the pancreatic cyst, the first question you have to ask you is this patient fit for surgery? Because if it's not, it's useless that you continue this expensive and stressful for the patient. All this follow-up is not necessary. If you find a cyst in an old patient, even if it have some suspicious aspect, but if the patient is not, will never go to surgery, it's useless that you follow up this patient. But of course, in the case I show you, there was a 30 years old female patient with this huge mucinous cyst, and actually we sent to you for evaluation of for surgery, and correctly you said before the procedure we need to exclude that it's not a serous cystoadenoma. You were right.
Are going to evaluate also main duct IPMN. Sometimes you are not sure if it's a real IPMN or just a dilation of the duct. And some surgeon can ask you to puncture it. What's your point on that?
Well, I think, of course, sometimes it's difficult to define a main duct IPMN, especially for those with a size in the range between 5 and 9 millimeters. So you find a main duct of 8, 9 millimeter, and you don't know how to manage it. I think actually puncture, the punction of the main duct is not recommended because of also the risk of fistula, pancreatitis. Yeah, so according with the last guidelines, if you have this range of size, or again, if it's fits for surgery, you could shorten the follow-up, of course, after speaking with the patient and always a multidisciplinary evaluation of the patient, I think. And the other problem, I think, is to distinguish if you have a branch duct IPMN with a dilation of the pancreatic duct. So that could be worrisome features of the branch duct, distinguish it from a mixed type IPMN. And I think it's not clear, neither in the last guidelines. It's written that it's not easy to distinguish between those groups. So I think till now we have some still persisting doubt in the management of this lesion.
What's the point of the surgeon about that? If you have a patient with dilation of the Wirsung duct without chronic pancreatitis, are you going to follow it? Are you going to speak with the patient for surgery? Or do you want a puncture of the duct? Or?
So first of all, I would like to thank Livia and Matteo for inviting me. It's a pleasure and honor for me to be here in this setting and also in this with this panel, which is very high profile. I would like to thank you also, Serena, because she highlighted very interesting issues. First of all, I'm not sure that we need to puncture every cyst in the pancreas. And to be honest, for the lesion in the tail of the pancreas in a female middle age, I think that we need to think about mucinous cystic neoplasm rather than serous cystadenoma. However, as you showed, it was difficult to distinguish between one or the other. But with glucose level, I think that you have many information.
Yeah.
When you have a dilation of pancreatic duct in the setting of chronic pancreatitis is one thing. When you have a main dilation of pancreatic duct in a branch duct IPMN, I think that the surgery is the answer and you don't need to do any biopsy or fine needle aspiration. I have only two questions for you. One is a consideration. And the consideration is when we see the report from the gastroenterologist, from the endoscopist, I think that the report is the most important thing you have. I mean, when you describe the lesion, you describe the pancreatic duct, the cyst, you describe if you see a nodule, you describe also with the contrast enhancement, which is the behavior of the cyst. And I think that this is the most important thing rather than the biopsy. Mm-hmm. Because if you see the report, you can think about what you have in your mind. So if you have a mural nodule, you can see, reading the report, if this is a plug or if the nodule is a suspicious nodule. And other question is, when you follow the patient with the cyst in the pancreas, do you think that if you do an EUS in a patient with the worrisome feature and the surgeon is not keen to do surgery in that patient, not because he's not fit for surgery, but because, as you said, because in a worrisome feature you can also follow patient, do you think that you need to do EUS every step of the follow-up, or would you do, for example, an MRI and then EUS?
Thank you. To answer your first question, of course, the report is very important because, as I said, it's all operator dependent. So it's not that you can review like a CT scan on MRI. So I have to. You have to trust me, of course, of what I say. But the problem is that, as I show you, the inter-observer agreement between endoscopy is not so high for the morphological aspect of the cyst. And about the contrast enhancement in studies, the data literature showed is a higher inter-observer agreement power. It's good between endoscopies. So I think I agree with you that we have to use some tools that we have, especially Sonoview, the contrast, because it's not an invasive technique, so it's easy to perform, it's quick, and it's nice because it can help us to distinguish the possible worrisome features. And of course, we have to let you understand what we saw during these live procedures. So it has been written very well, especially for the surgeon or for the other doctors who read the report. But
yeah, this is the point, because if I have a CT scan, I can read the report,
yeah.
but I can also see the images. Okay, in the during US,
yeah, of course, you can see the video of the procedure, but I think it's a different different expertise. I think about the follow-up. I think it's MRI is sufficient for follow-up this the cystic lesion that has no worrisome features. Of course, especially in older patients. And because, of course, US, it's true that is the ideal tool for the evaluation, but you have to think that it's not adverse event free. You need to sedate the patient that usually have some comorbidities. So you have to think about when there is the right recommendation for it.
This is a provocative question, Serena. You have a 60 years old 60 years old lady with a branch duct IPMN, with initial dilation of the main pancreatic duct, 5 millimeter. And she comes to my outpatient clinic and I say, let's see in 6 months what happened. Would you do another US or MRI?
No, I think if the first image is an MRI, maybe after 6 months, one US, I would like to perform it. If it's stable after 6 months, maybe I could follow up these patients just with MRI till there is not something to change.
Thank you.
Can I ask you one question? Sorry. But do you have age cutoff till you operate this kind of patient with a not clear, of course it's not an adenocarcinoma, but if I send you a patient, I don't know, 85-year-old that is fit for surgery and it has some 3 worrisome features of disease, do you?
Well, 85 years old, I would say no.
No.
For a worrisome feature IPMN. With the adenocarcinoma, it's completely different, obviously, but we do not have any contraindication based on the age.
Okay.
But it is based on fitness of the patient.
Okay, thank you.
Thank you.
Basta.
Serena, just the last question from the audience. We can show it. Are there any AI tools that could be useful for the differentiation of pancreatic cysts?
For the studies are emerging about this aspect, and the interesting thing could be to, of course, collect. First of all, you have to collect all these suspicious images and for create a kind of library, and then that could be interesting to I don't know, while performing the US have this indication of some features like I don't know, the nodules, the honeycomb pattern, the dilation. Of course, it will be the future, but by now there are not some standardized tool that allow this, but we are working on it. Thank you.
Okay, I have the opportunity and the pleasure of introducing, I don't know, Daniel de la Iglesias Garcia, who talking about indication for EUS in pancreatitis.
Buongiorno, grazie Livia, grazie Matteo for the invitation to be here. It's a great pleasure to be another year in this Generation Eus. And the topic for me today is the indication of US for pancreatitis. And when I'm thinking what are the indications of US in pancreatitis, these three comes to my mind. The first one is in the diagnosis of the etiology of idiopathic acute pancreatitis. Around 10 to 20% of patients after an episode of acute pancreatitis, we cannot get the diagnosis. Another main indication for me is in the evaluation of patients with chronic pancreatitis, which is the role of the US in the diagnosis of early chronic pancreatitis. And finally, and probably the most important one the last year, are in the management of patients after an episode of acute pancreatitis, especially when they have wall of necrosis, and this is probably the most important advancement in the last years regarding the use of lumen-opposing metal stents. Probably this is the same protocol that you use in your hospital when you are evaluating of a patient after an episode of acute pancreatitis. Usually we perform a complete personal history, we perform abdominal ultrasound and a simple blood test. After this evaluation, usually we get the diagnosis, biliary stones, alcoholic etiology. But if we don't get the diagnosis, we usually ask for a US. Why? Because we know that the US, we can identify other etiologies like microlithiasis, small tumors. If after the US we cannot get the diagnosis, is when we think in perform an MRI just to evaluate other possible etiologies of the idiopathic acute pancreatitis. As I said, with the US, we can identify this small sludge inside the gallbladder that can be the etiology of acute pancreatitis. We also can identify this choledocholithiasis inside the common bile duct, or in some cases, we can identify an sphincter dysfunction during our examination of these cases of patients. There are several studies that evaluate the role of US after an episode of acute pancreatitis or after an episode of idiopathic acute pancreatitis. I come with this example from 2020. They evaluate almost 1,500 patients after an episode of acute pancreatitis, and look, the diagnostic yield of the US was 60%. I mean, 60% of patients without diagnosis, we can get the correct diagnosis with the US. The majority of patients obviously have biliary stones in the gallbladder or the common bile duct. 12% of patients have a chronic pancreatitis, and 2% of them had a tumor in the pancreas that explains the cause of the acute pancreatitis. Well, I developed a very simple quiz about a theoretical battle between US and MRI in the diagnosis of idiopathic acute pancreatitis. For example, in your opinion, which technique is the best to identify biliary disease? Please raise your hands because we don't have this new software. In your opinion, which one do you think that is the best technique to evaluate biliary disease? Raise your hand. Okay. And case of MRI, raise your hands. Well, obviously, the best technique to evaluate biliary disease is the US, far away from MRI. Identifying chronic pancreatitis, again, the best technique is the US, with an odds ratio of 2. When we try to evaluate the presence of a pancreas division, the best technique is, in this case, the MRI. However, the results are not statistically. And overall, obviously, the best technique to evaluate a patient after an episode of idiopathic acute pancreatitis is the US. And finally, when we are talking about the evaluation of patients with cholestasis with a suspicion of a choledocholithiasis, in a lot of centers, they still think that the best technique is the MRI, but this is wrong. The sensitivity of the US is better than the sensitivity of MRI to diagnose, to diagnose the presence of biliary stones inside the common bile duct. Coming to another topic, we are talking now about chronic pancreatitis. Chronic pancreatitis is very easy to diagnose in the last stage of the disease, especially when the patient develops calcifications, like in this image with the presence of stones and a dilatation of the main pancreatic duct. And there are several studies that evaluate the role of different techniques, and it seems that the US is better or has a better sensitivity for diagnose patients with chronic pancreatitis, and for that reason, the US is in the top of the scale of the accuracy in the evaluation of patients with chronic pancreatitis. However, sometimes we face this problem. We find a patient with early change of chronic pancreatitis. What are these early changes? The presence of strands, focus, irregularity of the main pancreatic duct. And we have doubts about what is the meaning of this change. This change means nothing. There are a very calm sea without expectation of any change. However, this change in the correct clinical context, that means something worse. A storm is coming. Therefore, in Santiago, develop a multimodal US approach in the evaluation of patients with early change of chronic pancreatitis. This approach was based on the performance of the US and elastography to count the number of US criteria and evaluate the degree of fibrosis based on elastography. We inject secretin to measure the distensibility of the main pancreatic duct at different times. And finally, we collect all the juice coming out from the main pancreatic duct to measure the bicarbonate secretion of the pancreas, because this bicarbonate secretion is the gold standard for diagnosing early chronic pancreatitis. Based on this approach, in our cohort of patients, of 50 patients with epigastric pain with normal gastroscope and 3 or 4 US criteria, we found that 60% of patients have the 4 tests are normal: degree of fibrosis by elastography, distensibility, and low levels of bicarbonate. Therefore, 34 patients actually have an early chronic pancreatitis. It's a complex procedure, obviously, but it helps to identify that patients with early change that actually have an early chronic pancreatitis. And coming to the end of my talk, one of the most important roles in the last years was the therapeutic role of the US. Thanks to the US, we can drainage and we can treat wall of necrosis using lumen apostle metal stents, but also we can have access to the pancreatic duct to drainage by pancreatogastrostomy in patients with obstructive chronic pancreatitis, and also we can treat pain performing a blockage of the celiac plexus during US. To conclude, US is the most sensitive technique for the evaluation of the cause of the idiopathic acute pancreatitis and to identify change of early chronic pancreatitis, and US plays a pivotal role in the management of complications, both acute pancreatitis and chronic pancreatitis. Thank you very much for your attention. Any doubt, any suggestion, please.
Thank you, Daniel. I have a question for you. When you want to judge a pancreas after an acute pancreatitis, do you expect 1 month, 2 months? Because we know that during the acute inflammation, you cannot really judge all these really tiny alteration of the parenchyma. What do you think?
Well, here it depends what is your suspicion. You are suspecting biliary etiology of your acute pancreatitis. You suspect that your patient may have choledocholithiasis. In this case, you should perform during the in charge of the patient. However, if you discard the presence of lithiasis as the etiology, we should perform the US after 6 to 8 weeks of the discharge of the patient with acute pancreatitis.
And you talk about the identification of a small stone microlithiasis during EUS, but sometimes after an acute pancreatitis, it's not so unusual to see patients with long fasting and intravenous parenteral nutrition. I know it's not correct, but it's not so unusual. And you can see some biliary sludge. Do you rely on this finding on EUS, or how can you judge it before sending the patient for cholecystectomy or ERCP? It's not an easy question.
Yeah, this is a key question. Sometimes we cannot talk about cause because we don't know the relationship. We identify some risk factors. The sludge is a risk factor for acute pancreatitis, and therefore you should have to decide between send the patient for cholecystectomy or just to wait for another episode of acute pancreatitis. Probably, suspecting that biliary is the most important etiology, as soon as I identify a sludge, I recommend the patient to go to the theater.
Daniel, thank you very much for your presentation. I have one question, which is, you said that the EUS is superior to MRI also in the identification of choledocholithiasis, yes? It's correct, yeah?
Yeah, no doubt.
Yeah. In my hospital, it's easier to have an EUS rather than an MRI, so I'm lucky, okay? But if we think about most of the hospital, for example, in Italy, if you have suspicious of lithiasis in the common bile duct, they usually say you should do MRI first and then EUS, because it's difficult to have EUS in all the hospital in Italy. So I think that all these studies you showed are probably from from referral center for HPB. My question is, do you think that we should centralize all patients with HPB problem to eye referral center, or do you think that can be managed in all the hospitals? Because it's difficult, you know, if you have cholecystitis and you are in doubt to have also a gallbladder stone, you should refer the patient to the referral center.
Mm-hmm. I think that I understand your point. I think that is something from the past. In the past, it was more easy to have an MRI machine in the hospital than an endosonographer to perform all these tests. Fortunately, look, there are a lot of people here interested in US, and the training for being able to identify lithiasis during the US is not so difficult. After 2-3 months, any of us are able to identify this. Therefore, I would recommend to have more endosonographers rather than more radiologists in the hospitals. And this is my opinion. Well, I come into the Serena talk. I follow patients with cystic lesions. I trust more in my US rather than in the report of a radiologist in case of cystic lesions. Therefore, in my clinical practice, I tend to perform the follow-up of patients with cystic lesions with US. I know the guidelines, what I said, but I'm the doctor that have to explain to the patient what we are going to do next. And with the US, I can evaluate all the worrisome features of a cyst, and I can decide based on my US, but I cannot decide based on the report of a radiologist only. Okay, thank you.
Danny, sorry. I know that I should shut up, but I have a very brief question. No, sorry. Do you think that in calcific chronic pancreatitis, US is a good indication? I think no. But
is as bad as the MRI. Thank you.
Okay, I also introduce Marianna Signoretti on the podium, speaking about I have to talk about the mediastinum submucosal lesion.
Thank you so much. I want to thank the organizer for having me here. This is an outstanding course, and I'm going to speak about submucosal lesions. First, I want to underline that this is a bit confusing because they don't come from the submucosa. So it's better to call it subepithelial lesion because the origin of this lesion can be either muscularis mucosa or submucosa or muscularis propria. And EUS is the key point because with the white light on, even with the new technique of imaging during a gastroscopy, you can really differentiate between all these lesions. And the EUS is the best method to determine all these 5 echogenic layers that you can see. Let's see if we can point, maybe. Okay, no, I'm not good on that. So you see the mucosa is the whitish first layer with the muscularis mucosa. There is this dark one, that the submucosa, and the muscularis propria and the serosa. That really helps to distinguish all these lesions. So I will do all the way around compared to my colleagues. I will start to test your knowledge with some clinical case, and let's see. So this is a female, 54 years old. She underwent a gastroscopy for reflux symptoms, and a tiny subepithelial lesion was found incidentally at the level of the body. Byron bite biopsies were negative, so we start with the EUS to characterize the lesion. As you see, it's really small, not Doppler inside. It's a bit homogeneous with this tiny echoic area inside, and it seems to come from the submucosa layer. So, which is the next step? Performing an EUS FMB, surveillance with EUS, surveillance with a gastroscopy, repeat Byron bite biopsies, or no follow-up is required. So please vote. Let's see. What would you do? So it's a really small lesion. So surveillance, no follow-up is required, or surveillance with gastroscopy? Yes, I knew it because, of course, seems really benign, but in my view, you don't have the stigmata of pancreatic arrest, if that's what you are thinking about. So I would put in on a surveillance with the gastroscopy, but we are going to see it later on. So, go on. We have the second clinical case. We have a male, 65 years old. He went to the emergency room for loose black tarry stools and a severe anemia. So first upper gastrointestinal endoscopy was performed, and 4 centimeter subepithelial lesion with an ulceration on the top was found without an active bleeding at the time, and then we perform an EUS. As you can see, we can see a bleeding again of this lesion. And so we start to understand more about this lesion, about the EUS features. As you can see from the arrows, this is the transition zone, and this seems to come from the muscularis propria. It's a very heterogenic lesion with this central area, anechoic central area. So, which is the next step for you? Performing an EUS FMB. Ask for a direct surgical resection, performing a mucosal incision assisted biopsy, endoscopic resection or surveillance. So let's see the results. So you're going to an FMB. And then the second is direct surgical resection. So this is a second bleeding of course, we can say it's not a massive bleeding, but it was really important. So maybe a direct surgical resection is required. There we see that ESG guidelines suggest to do so. So let's go to the last, last clinical case. So it's a female, 34 years old, no relevant medical history. She underwent an echocardiogram, and they found out a lesion close to the esophageal wall. This is a gastroscopy that confirmed the bulging and the distal esophagus. And you can see this lesion. We can call it lesion. It's really inhomogeneous, maybe as a echoic area inside. It's anechoic, and no Doppler, no signs of vessel inside. We could just see this echoic enhancement at the bead mode, very strong, like aorta. Seems like something like that. So let's see what is the most likely diagnosis for you: a leiomyoma, a GIST, or a duplication cyst, neuroendocrine tumor, or lipoma. So let's see real time the answer. Okay, I agree with you. Because of that, maybe I told you some important details. So we can go on with my presentation. So first, when we are speaking about submucosal lesion, you have to know that in different parts of the GI, you have a common lesion and uncommon lesion. So first, you can predict which kind of lesion you are going to evaluate with US. And when you evaluate a subepithelial lesion, you have to see the layer of origin, as I said, the size of the lesion, because it can be bigger compared to the bulging that we saw during a gastroscopy, for example, the margin of the lesion, the echogenicity of the lesion, because an echoic lesion is a full-field structure, is benign, and a strong hyperechoic lesion could be a lipoma. You can rule out benign lesion, and of course you have to check for lymphadenopathy. So this is an overview of all the submucosal lesions that we can found. And as you can see, they can be in different layers. They can have different echogenicity. So US alone cannot really distinguish between all of that. But we know that we have to have a good imagination. And we know that liquids can help. We already talked about that. So you have to use water because you are, in the majority of time, looking at really tiny lesions. So you have to have water that can help you to judge the lesion, but you have to pay attention about aspiration. In stomach or esophagus, you have to be really careful. And in my opinion, you have to use every time a balloon because it really helps to reduce the artifact. And I already told you that this is the transition zone with the big blue arrow, and this is the area between a normal wall and the lesion. You have to put your scope perpendicular, and then you can see better where a lesion born. And also, it can help to judge the overlying layer of the lesion to be sure. So we can rule out some benign lesion that doesn't need any follow-up or biopsy or nothing else after your US, so pancreatic rests. So if you have this typical umbilicated lesion and the US is negative, just stop follow-up, or you can have a cystic duplication cyst. And like in the third case, this acoustic enhancement, it's an artifact that in this case helps you to distinguish between full-filled liquids structure to very hypoechoic structure. So it was the liquids. And also, of course, the lipoma that has some really clear characteristic with like a pillow sign, and they are really hyperechoic. And we have to rule out also the false subepithelial lesion. So viruses, for example, it's really easy. You just have to put your Doppler signal and you can see that this is a vessel inside. And also a non-GI lesion, like a compression by surrounding normal organs, or lesion like spleen. And this is a real bulging that my colleague saw during a gastroscopy. He asked me to have a look with a echo endoscopy, and it was just a gallbladder. So as you can see, it's really close to the antrum, and we can see this bulging in the antrum very often. So about the contrast enhancement, it can really help to characterize the lesion, and ESG recommend to use it, but it cannot replace the tissue acquisition. So yes, you can rule out benign lesion if no contrast is present, but you have to go for biopsy if you are not sure about the diagnosis, as the lesion has some high-risk features. So in this case, as you see, we have this really an homogeneous lesion, and so after contrast, we see that in the first arterial phase, there is a hyper-enhancement with all these tiny vessels inside, so we have to biopsy it. And this is the results. And it can help also to distinguish between GIST and leiomyoma that doesn't have this enhancement. We don't have enough data to recommend to use elastography, but if you have it, why don't you push the button? And you know that, for example, the GIST are really stiff compared to lipoma and leiomyoma, so it can help. And also the DFI that can shows all these tiny vessels without giving contrast, so just pushing a button again, and you can see all these vessels inside a lesion that could be GIST. So biopsy is indicated when you think about malignant, or when you have a lesion larger than 2 centimeters, or that grows during your follow-up, or in presence of ulceration. So of course, if you have some high-risk features like irregular border, heterogeneous echo patterns, or presence of lymph nodes, think about biopsy. And ESG guidelines suggest to do that for this reason. Even if you have a look at some other guidelines, they suggest to biopsy all the lesion, even if less than 20 millimeters, if you think they are GISTs. But of course, you have to go directly for a surgeon if a severe bleeding is coming out from this subepithelial lesion. And we can biopsy it with the EUS for sure, but bite-on-bite biopsies have a really low yield, so they cannot really give you a diagnosis. But now we have this new technique with an roofing the lesion and making a biopsy direct of the lesion. All of them, they are called mucosal incision assisted biopsy, and guidelines suggest to do so for lesion less than 20 millimeters when we want to know the diagnosis, whilst for lesion more than 20 millimeters, we can either choose FMB, that seems better than FNA, even if FNA withdraws, it's always available, could be competitive. But in my opinion, I've never done this kind of biopsy. I think you should be skilled. You have to have some devices that is not present in every endoscopy. And if you are doing EUS, why don't you go directly for an FMB? So some of them you can put on surveillance, like the first case. If you have a tiny lesion, you can just follow up with the gastroscopy, whilst duodenal and colorectal cells, you just have to go direct for a diagnosis. So you see in the center EUS of the algorithm. I just want to close with the last slide. AI has a role even in this kind of lesion. It seems to work better than human endoscopists. Let's see in the future. This is already a meta-analysis of 8 retrospective studies. So this is in summary what we already said. So just to save time, I just want to say thanks to all of you and to my brand new team in Rome, and see you in Rome wherever you want. Thank you.
Can I ask you, sorry.
Yeah,
No.
very quick question. Very quick.
Short question.
Yeah.
In a case you have patients with a small, like 2 centimeters, that is borderline size, that is could be resected endoscopically, and at EUS it seems like a GIST. Do you think it's necessary, well, also with the contrast, hyper-enhancement contrast,
exactly.
do you think it's necessary the biopsy? You always
Yeah,
in histology.
ESG guidelines give you the chance to go directly for a resection. You have to think about the age of the patient in case of a young patient, or in case of patient who wants really to go direct for resection. You can think with the patient, decide together. Of course, in the East country, they go directly for the resection, even if they are less than 2 centimeters. And for ESG, you can both decide the resection directly or biopsy it.
Okay, so it's my pleasure. Thank you, Marianna, first of all. And it's my pleasure to introduce Dr. Lisotti on the last part, on the medicinum, and then we'll go to coffee break.
Thank you, Livia. Okay, I just have to talk about the indication in debatable disease, when to debate, and maybe the medicinum is one of the main place where to debate about the indication. I want to introduce my talk speaking about my roadmap arriving in Next Generation Eus. I received a phone call from Matteo an evening. There are 7:30 p.m. and there are several procedures left in San Raffaele schedule, and I'm already having my aperitif. And Matteo just asked me, Livia and I would like to have you in the faculty of Next Generation of Eus, and of course I'm on board. But he told me I have to speak about the mediastinum, so I feel like a boss, so it's not a problem. I feel confident about the anatomy of the mediastinum. And he said, well, someone else will speak about the anatomy. You should speak about debatable indication for mediastinal Eus, something peculiar, catchy, innovative. So the line breakdown, and I have made some consideration. I did something wrong to Livia and Matteo in 2023, but someone else did something more wrong than me in 2023. So Dario, we can share our topic. And I would like to talk about to you, because to switch off the ultrasound processor when pulling back the Eus for scope from the stomach, it's not a correct attitude, and someone of us did it. Why? Because we have several correct indications in mediastinal Eus. We can start from lung cancer, the mediastinal nodal staging and tissue sampling. Dario introduced us the mediastinal anatomy, speaking about upper nodal stations, peripheral nodal station, and some nodal stations like paraesophageal, paraortic, and 4L, 4R, and AP window that could be assessed both from transbronchial ultrasound and transesophageal endoscopic ultrasound, could be integrated. And the integration of endoscopic ultrasound with to transbronchial ultrasound increase of about 13% the sensitivity of EBUS alone, of transbronchial ultrasound alone. And the guideline written by Peter Willman about 10 years ago suggested that the introduction and implementation of EUS allowed to give us the complete information about the nodal mediastinal staging, and mediastinoscopy is no more needed, but they say that EBUS alone, it could be an acceptable alternative if USFNA is not available. And about lung cancer tissue sampling, we know that lung cancer tissue sampling is fundamental to change the management because of targeted therapy, because of immunocheckpoint inhibitors, and so on. And the guidelines suggest that the less invasive procedure should be suggested. But unfortunately, sputum cytology or pleural cytology have really insufficient adequacy. Also, a standard flexible bronchoscopy has an insufficient diagnostic yield. So, in selected cases, when bronchoscopy and EBUS is not diagnostic, when transthoracic CT-guided tissue sampling is not diagnostic, EUS FNA could be considered for centrally located tumor, and EUS FNA could be diagnostic in case when other technique fails. It is interesting that we have a huge amount of literature about EUS FNA, 11 studies, and they say that the sensitivity is about 90% in diagnostic lung cancer. And we conducted a retrospective study in Italy comparing just 47 patients, comparing USFNA and USFMB, and we saw that USFMB allowed an increased sensitivity and diagnostic accuracy. And on multivariate analysis, the tumor size greater than 15 millimeter and the use of FMB needle are independently correlated to diagnostic accuracy. I thank the group of Palermo and Giacomo Rizzo and the entire group provided me their experience, their prospective experience on 31 cases prospectively 43 cases of prospectively collected patients with centrally located tumors. You can see the procedure is not difficult, it's not complex. We can identify the centrally located tumor and we can go for FNB. And the authors will present the complete results on a diagnostic adequacy of 93% with a diagnostic with a specificity of 100% and a sensitivity of 97.3%. The authors reported just 2 adverse events of 5%, significantly less than EBUS or bronchoscopy of course, transthoracic CT-guided sampling. We have to remember that bronchoscopists can perform transesophageal sampling even with the bronchoscope. So these authors recently reported that in 276 cases, about 15% of their entire casuistic, also a transesophageal USFNA have been performed, and they allow an increased 3% of diagnostic yield in case of an accessible lesion from the bronchus or trachea, or inappropriate conditions for bronchoscopy, such as respiratory failure or airway stenosis, or non-diagnostic EBUS transbronchial needle aspiration. Finally, we have to remember that also from the esophagus or from the stomach, we can access the left adrenal gland, that is a usual site of lung cancer metastasis. And we have also in this setting very good amount of data. We have 8 studies on 360 patients with a very good sensitivity of 95% of patients with no reported adverse events. But I would like to remember you that the beautiful meta-analysis in every topic we have should not be taken like the holy grail taken by Harrison Ford. Because I would like to introduce my own experience of a male of 56-year-old, an heavy smoker with a small peripheral lung mass, impossible to be accessed from the bronchus. He has brain metastasis, so CT-guided brain metastasis sampling could be an option, but he has a left adrenal gland mass. So we go further for US sampling. I performed sonoview injection just to assess a central necrotic portion. I went for a targeted FNB with the second generation FNB needle, and as I show you, no adverse event have been reported, but the patient developed a huge hematoma of the left adrenal gland, required interventional radiology that was not sufficient to stop the bleeding, underwent surgery. And the patient did well, but I spent a beautiful August 1 year ago with him. Moving some consideration for lung cancer staging and sampling is a routine indication for US, even for a gastroenterologist. And this indication must be debated or at least discussed with a multidisciplinary team with a good anatomy and disease knowledge And with pneumologists, we have to remember that pneumologists do not always need us, so we have to speak with them and collaborate with them. I'm moving rapidly to the second topic, that's the mediastinal lymph node assessment. We know that lymph node assessment on B mode could be distinguished between benign and malignant based on shape, border, and echogenicity, the presence or absence of vascular hilum, and also on Doppler analysis, the present or absent or vascular central vascularization. But EUS B mode can provide reliable information of a lymph node nature just in a small amount of cases. So we assessed several image enhancement techniques like contrast enhanced and elastography that report very beautiful results in clinical studies about an area under the curve of 95 or 97%, but not so higher in clinical practice. We started in an ongoing study, Anna, we have to conclude it, the implementation of elastography and contrast enhancement that can provide a good specificity for malignant lymph node, or the presence of a pathological condition on elastography or contrast enhancement with optimal sensitivity, but in the mediastinum is not so reliable. So in the mediastinum, we cannot trust on our image enhancement technique because we can have heartbeat or respiratory artifacts for elastography, or enhancement of respiratory movement and microbubbles in major vessel for contrast enhanced EUS. And what about tissue sampling? Tissue sampling in lymph node is very good. We have a specificity of 100% with an area under the curve of 99%. We performed a meta-analysis comparative between FNA and FNB. The FNA and FNB have similar diagnostic accuracy, but FNB needle provide significantly higher specificity, and the subgroup analysis on the mediastinal did not show significant difference. So in the mediastinum, FNB is superior to FNA to provide to exclude, to rule out pathological lymph nodes, but FNA is a valid alternative. So few consideration also for lymph node sampling. Mediastinal lymph node assessment is suboptimal on B mode, but also on image enhancement techniques. EUS tissue sampling is an excellent, shows excellent performance in terms of adequacy, accuracy, and safety also in the mediastinum. We can use FNA just for differential diagnosis. If we have to rule out metastatic versus benign lymph node, it's a good option, an FNA needle. But if we need immunohistochemistry or tumor biology or information about lymphoma, we require a second generation FNB needle. Take a long breath, and I move to the last part of my topic, mediastinal cyst. We talked about mediastinal cyst. This is the case of a male with a mediastinal cyst with increased in size. He was admitted for suspected hematological disease. I thank my colleague from Ancona for the images, and the patient was reported for tissue sampling of a mediastinal cyst. Well, I would provide you the indication of EFSUM guidelines that transesophageal US-guided sampling of mediastinal cyst should be avoided because of the risk of infection. Do not puncture mediastinal cyst. Why? Mainly because most of mediastinal cysts are benign, and the sampling do not change our practice. The two cases of cyst with a malignant nature have also on US solid components, so we can target the solid portion, avoiding the cyst, but it's another setting. So don't try this at home. Mediastinal infection. I would like to just report the case that mediastinal infection could be drained from the esophagus. It's a good place for interventional EUS, but I would like to show you that Michel Calais reported this case just 20 years ago. So it is really, it seems like a debatable indication, but it's 20-year history. Finally, vascular intervention, also Dario spoke about that. We can access and treat variceal bleeding or gastric fundus varices. We can measure portal pressure. We can also access the art and make cardiac intervention, there is also a report on thrombolysis guided through an USFNA needle, but we are talking about a few cases in really debatable indications. This is a case of published last year of a completely benign area of the heart punctured on USFNA. You can do it, but you have to talk about it. And finally, we can have also incidental findings. So this is the case of a female patient with mild exocrine pancreatic insufficiency, so as Daniel talked about us, but the endocrinology consultation report about primary hyperparathyroidism with increased parathormone and reduced calcium, and increased calcium. You can see the anatomy of the neck. This is the trachea, as Dario showed us, could be an indirect marker. This is the parathyroid, the right parathyroid. We turn the scope counterclockwise. And we see in the lower part, lower than the parathyroid, an anechoic, an hypoenhanced area. We tagged with an USFNA needle this portion, targeted much on US, on contrast enhanced US, and the result is that there are non-atypical epithelial aggregates, positive on immunohistochemistry for parathormone secretion, and the level of parathormone are really increased in the eluate of the liquid. So the conclusion is the ectopic parathyroid with the presentation. So in conclusion, knowledge of mediastinal anatomy and disease is fundamental. The multidisciplinary team group, even if you speak about mediastinal indication, should include also pneumologists, bronchoscopists, and thoracic surgeon, and always discuss and debate about borderline indication. Do not do by yourself. Thank you for your attention.
Thank you, Andrea. Next year you will have the rectum for this presentation.
Okay.
And I think we can go to the coffee break, and we will see here in 15 minutes.
questa è mezza iniziata, io gliela lascio.
Okay, please, take a seat.
We'd like to invite you all to take a seat so we can start again after the coffee break.
I've been brief.
And I'm more polite. So we can start this session on devices. Devices are very important for all of you who perform EUS, but also, as we know, most people that learn how to perform EUS also learn ERCP. So devices is something that is very, very important to know how they're built, the dimension, what you have at your hand that you can use, and how to use them. So I'd like to invite on stage the first speaker for this session, Jessica Dominguez Novoa from Spain, who will talk about the needles. All the needles you can get. Please, Jessica.
Okay. Thank you, Matteo and Livia, for inviting me to be here today. And we are going to talk about all the needles we can use during our procedure and some questions we may have during the procedure, okay? We all know that the US indications have been increasing over the time, but the main question here is when is tissue adhesion recommended, okay? And here there are some indications published in the European guidelines, and we can see here the indications are pancreatic tumors, pancreatic mass, chronic pancreatitis, lymph nodes, submucosal lesions, luminal cancers, adrenal lesions, liver lesions or parenchymal disease, and mediastinal tumors, with an overall accuracy between 75 to 95%. And here in this image, we can see the evolution of the needles over the time, okay? The first needles we had in our rooms was cytology needles, and then core needles or histological needles appeared. The first generation of core needles was reverse bevel, and in the second generation, we call them the real core needles, okay? We can distinguish between Francine or fork tip needles with the difference in between the tip of the needle, as we are going to see below, okay? Well, if we have all the options in our room, here the question is, which type of the needle should I use in each case? Before we can choose one type, okay, we need to have three main important things in our mind, okay? The first one is that we should try to get an adequate and enough sample to have a diagnosis, okay? The second one is it's usual to need more than one pass, and we have to assess where we are. It's different to be in the stomach than in the duodenum, and it's different to have a lesion in the uncinate process than in the body of the pancreas. And the third one, but not less important, is that we should perform the safest procedure we could, okay, with low complications. So then, now, should we use an FNA? Should we use an FNB? Here we have two images. The first one is a cytology sample, and the second one, here you have a cell block in a histological sample, okay? In lesions, we need a specific diagnostic. We need to increase diagnostic yield, to do molecular testing, to do molecular targets, and we need more, nowadays we need more and more samples for researching. So now we try to get cell block histological samples, and it's the reason to use FNB, okay? And here we have the first generation of core needles, the reverse bevel. If we compare them to FNA, we have here a meta-analysis, and it has been seen that they are similar in terms of diagnostic accuracy, without difference of optimal histological course, but we need a lesser number of passes with core needles, okay? And we move on to the new generation of core needles, okay, Francine and fork tip. We have here the Francine tip, okay? and it is known as chrome needle because of the tip. And here we have the fourth tip with a largest tip to introduce into the lesion, okay? And if we compare the reverse bevel with new generation core needles, okay, we can see that the new generation, Francine and 4-tip, have a higher sensitivity and accuracy than the reverse bevel needle, okay? And if we compare both types of new generation needle, okay, Francine and 4-tip, we can see that they are similar without difference. And if we compare, and there are several studies comparing FNA with FNB, and we can see in the second table that FNB have a higher diagnostic adequacy compared to FNA, but not only if we analyze all the lesions together, but also when we analyze pancreas lesions, lymph nodes, submucosal lesions separately, okay? And in the first image, we can see a meta-analysis with results in favor to FNB again. Two more studies comparing FNA with FNB. We can see in the first one that Francine, the new generation, is superior to the cytology needles in the accuracy per pass, and with lesser number of passes using MOSE. MOSE means macroscopic on-site evaluation. We are going to see below an image of MOSE, and here we can, using MOSE, we can see or we can test quality and quantity of the sample. And in the second image, we can see a study comparing Francine and 4-tip with FNA, okay? And they have highest performance of tissue sampling of pancreatic masses. But what about on-site evaluation? Here we have some studies comparing FNA and FNA with ROSE, and it has been seen that FNA with ROSE have a higher diagnostic yield. And in the second table, we can see that we can achieve using ROSE an overall diagnostic accuracy up to 97%, but independently, that is important, independently of needle size and technique used. Once we know that we should use ROSE when we use FNA, what happens, should we use ROSE when we do an FNB, when we use core needles? Here we have a study published in 2021, and they compare FNB and FNB with ROSE, and they saw that they were similar in terms of diagnostic accuracy with less procedural time using core without ROSE, okay? And here some results of our group in Santiago. We compare FNB and FNA with ROSE. We saw that they were similar in terms of sensitivity and overall accuracy, and we need a lesser number of passes with core needles and without the use of ROSE. We are going to move on another concepts we may have during the procedure, and one of them is the needle size, okay? What happens with the needle size? There are no difference between needle size talking about cytology needles in terms of diagnostic accuracy, but it seems to be more important the needle design than the needle size, okay? The most important here is individualize each case. We may need, in some cases, more unpreserved sample in cases, for example, of lymphoproliferative disease or autoimmune pancreatitis. And the bigger we could use, the better, okay? And there is one more, that is the liver biopsy, in which we must do a 19 core needle biopsy, okay? And what happened with the number of passes? How many number of passes should we perform during the procedure? This study in 2021 analyzed that doing 3 or 4 passes with a core needle, okay, we can achieve an overall accuracy between 88 to 94%, and this is the recommendation. But when we use ROSE, when the pathology is in the room, we used to do more passes, okay? And about the technique, it depends, okay? Here we can see a meta-analysis comparing slow pull with suction, and we can see that they are similar in the adequacy and the accuracy, but with a higher blood contamination with suction technique. And should we use fanning or not? Better do it, because there are several studies comparing, for example, here, in this one, they compare slow pull with fanning and suction technique. And here we can see that using fanning, we have a higher diagnostic accuracy with a higher blood contamination, but in a low grade, okay? There's no difference in the high grade blood contamination. And before finishing, some of the results of our group in Santiago, we compare the three types of needles. We saw that core needles have a higher sensitivity and overall accuracy. And after that, we analyzed the factors associated with a higher diagnostic accuracy, and we saw that tumor size, rows, and the use of core needles were associated to a higher one, but not a number of passes. What do guidelines recommend nowadays? They talk about FMB, and why they talk about FMB? Because it's easy to have a diagnostic in the rare diseases. The sample is superior, is better, okay? We need lesser number of patients, we don't need rows, and it's easier to have a grade of neuroendocrine tumors. And the most important nowadays here, one of the most important things, is the personalized medicine in pancreatic cancer patients. It's recommended to do germline and molecular testing in the sample, but because they have a very big impact, not only for screening, but also for treatment, mostly in locally advanced and metastatic patients, to can choose the correct treatment for each patient, okay? And here we have a study. All the procedures were done with a 22 core needle, okay? And they compared 2 passes and 3 passes, and there were no difference between them. Here we have some videos in our room in Santiago. The first one introducing the needle, block the wheels and remove the distillate. Second one's doing the procedure, okay? In the third video we can see doing the slow pull when we remove the distillate, and after we used to do a suction, okay? And in the below videos we can see how our pathologists in room process the histological sample, okay? And in the last video, the cytology sample. The image you have below is like a mouse technique, okay? In which we can test the quantity and the quality of the sample. And some messages to take home is that it's important to have cytology and core needles available in our unit, okay? Core needles should be considered the best option because they have higher accuracy and we need lesser number of passes, and we don't need rows every time. But it's extremely important to individualize each case and to know what we want for each case. And in some cases in which we need ancillary studies or molecular testing, the bigger we can use, the better, okay? And that's all. Thank you.
Thank you, Jessica, for this great landscape on the problem that we can have with needles. And do we have any question from the audience? Are you sure? Oh, great.
Thank you, Jessica, for your talk. From the practical point of view, which type of needle did you choose to puncture a lesion at the head of the pancreas?
I used to do the biopsy with a core needle, with a 22 core needle.
Always 22?
Yeah. In the engineering process, we can change and we can use a 25 core needle. And if we have to repeat the procedure and we have the pathologist in room, we can start with a 22 or 25 cytology needle, and after that we do 2 more passes with a core needle, with a 22 core needle.
Okay, thank you.
So thank you for your presentation. Do you think that in case of difficult lesion like small neuroendocrine tumor, which are very hard tissue, there can be a space, still a space for FNA, even achieving a grading, a correct grading of the lesion?
Yeah, of course. If we can have enough material or enough sample to have the grade, we should try to get enough material to have the diagnostic of a neuroendocrine tumor. Totally agree.
There is a question there.
Thank you. You told us about the pathologist in the room, but is he waiting all day until you make the puncture, or he's coming for the puncture and then going back home?
We only call them when we have to repeat the procedure in a patient because we had not enough material to the diagnostic. But in the first punction, we usually do it without pathologist in room, okay? And when we need, for example, to repeat one, or it's a difficult case, and we think that we will have problems getting the sample, we can call them, and they come to the unit for that while, okay, during the procedure. But that's all.
And do you try yourself to put it on the glass and to see if there is like white tissue and so on?
Yeah.
Or?
We have a question from the app that is asking, for liver biopsy, what needle you prefer to use, and do you use low puller suction, and any use of heparin?
We used to do, for liver biopsies, recommended to use an 18 core needle, and talking about the technique, we use wet suction to do the procedure.
Okay. Do we have more questions? No? Okay, thank you, Jessica, for this presentation. And we move on with Cecilia Binda, that is going to present us a lecture on LAMS. So, please, Cecilia.
So, thank you so much for the kind invitation. So I will talk about LAMS, that in this acronym there's at least it's enclosed what really do this type of device. That has been probably one of the most important revolution in EUS devices that has opened a completely different way of thinking EUS interventions that are nowadays widespreading, as we will see all over the course, and especially in the second part of this course. So this is the role of LAMS, that are actually self-expandable metal stand, fully covered, that has this particular shape that is barbell-shaped, B-flange, that allows us to anchorage across a non-adherent lumen structure and are able to avoid or actually reduce migration. And over the years, this device has changed, and nowadays are also available new devices that has an electrocautery enhanced tip. So, and even this has been an important revolution and in this field. So the first question for me as history, I think, is important. Do you know who is the inventor of lumen opposing metal stand? So vote.
It can be philosophical.
So if everybody voted, let's see which are your. Okay, which are your answer. Okay, most of you know that it's not Tacelli, but unfortunately for him. And it's Kenneth Bean Möller. And I came through this, I think, really nice picture on LinkedIn recently
that is Kenneth Bin Möller with his nurse, the Simio, and these are the two mentors and the two inventors of this device with the first prototype of lumen-opposing metal stand. So I think that it's important to all of you know who are the guys that make this revolution. And the first publication of lumen-opposing metal stands is at least 10 years ago, and think how many road has been made in such a short time, because it's at least 13 years, so very few times for endoscopy. And these are today the main indication of which we can use this device for all these procedures that are mainly main indication, as already you probably know, are pancreatic fluid collection drainage, biliary drainage, gallbladder drainage, and nowadays probably would come even on-label indication, all the word of GI anastomosis. So it's a really word that is changing and changing very fast. And that's why that Mike Wallace really think that lumen-opposing metal stand has revolutionized the field of interventional endoscopy. And the use is widespreading. So you have to know this device because most of you that will perform not only biliopancreatic endoscopy, but probably all interventional endoscopy will face with this type of stents. This is what I think is the armamentarium that all of you that are LAMS user need to have. Regardless the type of lamps you have, and you see that probably at the beginning it was important to have, of course, a linear echoendoscope, X-ray, and because it was sometimes it cannot be a single-step procedure, you need needles, guide wires, so nothing so different from ERCP devices, okay? So this is why I truly believe that people that perform LAMS procedure should be also expert and has expertise in ERCP fields. So the first step of the procedure has been nicely shown in the first part of this journey. It's having a correct knowledge of anatomy and doing a nice diagnostic EUS. Probably not as good as Andrea Lisotti or Dario Rigresti do, but Matteo as well, but you have to really know and understand anatomy, because when you encounter it in difficulties, and you have to recognize which could be your mistakes and which could be, you have to see first which will be probably the issue that you will encounter during the procedure. So doing always a nice evaluation, a nice morphological evaluation and a good EU diagnosis before moving to the procedure. And of course we can have two roads for stent deployment. This is the wire-guided procedures that was for sure the first technique, because we had a stent that was not electrocautery enhanced, so we were in the era of cold lamps, and so it was not a single step procedure, but there were multiple steps, and each of these steps it could be cumbersome, and you really need a good feeling with your nurse while during all this passage. Sometimes you always need to perform all this passage if you want to deploy even an electrocautery enhance over the guide wire. But we are in the era of hot revolution with the advent of hot electrocautery enhanced devices, and that allows us to perform all this procedure without the need of exchanges, of device exchanges, in a single step procedures, and theoretically even fluoroless. And this is how you perform a freehand technique, so you don't need any guide wire if you want, and you directly proceed into the target, giving the engines that need to be on the right preset, that it's a pure cut current, and then you can choose to deploy the second flange using or the endoscopic view, because there's a marker on the devices that allows us to recognize where is the end of the device in order to correctly deploy it into the lumen, the second flange, or the intra-channel technique. Do we have any suggestion to which one do? Probably no, although some reports say that probably the intra-channel technique is safer, and so probably most of us that are LAMS user do this technique, although it's not mandatory. So probably depending on the situation, depending on the procedure, depending on your preference, you can perform both the technique. These are today the most common lumen opposing, lumen opposing metal stand, hot ones having on the market. As you can see, they have different shapes, different design that probably gives some advantages other on the others, but you have to know which are the diameter and the length of the saddle available for each device, because I think that it is one of the main topic of this procedure. So probably there is not one better than another. You can use whatever you have, but pay attention to diameter and saddle length, as we will see. The main differences in the device itself is that one, it's controlled by an assistant, so you need an assistant for stand deployment. And here you have a marker that allows you to say this is where it ends the deployment of the first flange and start the deployment of the second flange. The other two are single operator stand deployment, so you have some tricks in order to keep in mind which are the passage you are doing, so number 1, number 2, number 3, and number 4 here. And in this case, it's up to you and in instant deployment. So, second question. In which suit would you perform procedure using LAMS? Let's vote. So most of you will do having X-ray available, although we can do, in most of the cases, a fluoroless procedures. Some of you in a standard room. So, actually, probably I don't have the answer, but I go further to which I think are my tips and tricks for the procedure, regardless the type of procedure you are facing. So I think although we are in the hot revolution, the armamentarium for you it's unchanged, because in several occasions you will need all of this in case of complications or in case of tricky situations. So you should have an endoscopic room which is able to have all these things and at least X-ray. So I really believe that all these procedures should be done in an endoscopic suit that has X-ray available. Maybe they would be useless in 90% of the procedure, but what really count is that when you have troubles, you should have it. And here you can nicely see a LAMS over endoscopic view. So it's really, really nice in this echogenicity. So it's really good, but these are situations in which it's also nice to have X-ray, like in these edge procedures, or if you want to put a double pictate coaxially, which is now under debated for several situations. And another suggestion I will give you is choose the correct lamps for the right indication. And this is probably a suggestion. There are few data on that, but these are what I think I would choose in my daily practice. Some of these are supported by some literature evidence, really small, and other no. But as you can see, in case of walled-off necrosis, probably using a larger diameter lamps reduce the need of direct endoscopic necrosectomy, or as the French group suggests, in case of common bile duct, probably using a 6 or 8 millimeter stents allows you to achieve higher technical success. So think about it. And this is a case that we recently faced in our unit, thanks to Stefano Fabri that provides me the video, and was referred to our hospital because this patient has previous gallbladder drainage for acute cholecystitis through a transgastric approach using a 20 millimeter stent. So a quite huge stent. Then he was referred to us because he has a recurrence of acute cholecystitis. And this was we found. This is the buried lumps in the gastric fistula, in the gastric wall, and here is the duodenum after the pylorus. So the lumps, it's like has been fistulized with the duodenum. And there was also a communication with the gallbladder. And so we decided to remove the lamps, of course, but I think that in this situation I don't have the answer, but probably I won't, in my practice, put a 20 millimeter stent in a gallbladder, although this is probably a personal thought, and I don't know if this is the cause of this strange case that fortunately did not have any trouble to the patient, but you know, this is what I like to ask to the experts in the room. And this is, you can see nicely the fistula from the stomach, and here up gallbladder and duodenum. The patient would be referred to surgical cholecystectomy, as is now has been considered fit for surgery. So let's move on. Another suggestion for my side is take all the time you need to perform LAMS guided drainage, and take all the space you need and you have to perform and safely perform this procedure. So this is an example. This is a pancreatic fluid collection. It's not very large because, as we will see, it's at least 40 millimeters of extension, but it was symptomatic and the patient was septic. So we decided to drain, but it's not so easy to put lamps in this situation because we have several meters of space. So the collection is not so big, and the distance from the wall is at least more than 10 millimeters. And we will see we are in the fourth part of the duodenum. So even the stent deployment, the deployment of the second flange could be at least tricky. So here you can see we go with the cystostome at the end of the collection. So we take all the space we need in order to safely make the opening of the first flange, which is very slow. If this was necrosis, probably the first flange would have some issues in the opening, and so give him the time, the correct time in order to make it opening in the correct way. Then we start the intrachannel release technique of the second flange, as you will see. But from this endoscopic view, you will see that it was a 15 millimeter in length saddle lamps. And as we were in the fourth part from the duodenum, it was not so easy to pull out without determining a misdeployment of the lamps. And it was not so easy to have the space for the correct deployment outside of the working channel of the scope of these lamps. So we need a little bit to pull it out without making all the lamps migrating into the collection. And this is the endoscopic view at the end of the procedure. So you see how in this situation, in the fourth part of the duodenum is very small, the lumen. So you have little space, and this could be a tricky situation. So, question 3. Would you use guide wire in a US guided drainage or anastomosis with lamps? Let's see. Okay. So here is really it's really not defined. Probably most of you, depending on the procedure, and 25%, so not negligible, yes, ever. And here is a case in which I try to assume it's guide wire a friend, as is often is, or it could be a false friend. And this is a case of gastric outflow obstruction due to a paraduodenal pancreatitis in a patient that was considered unfit for surgery. And so we decided to perform an EUS-guided gastroenteral anastomosis. But as it was a benign indication, we thought, okay, let's stay safe and let's get the access with a freehand technique and then place a guide wire in order to have safe the way we gain. And so we get into the, as you can see with the cystotome, then we push the guide wire, and the guide wire push out away the loop out from, and the cystotome was now out from the loop. So in this case, probably the loop, the guide wire didn't help us, but we can safely go on for and complete the procedure as well. But be aware sometimes from guide wires. And no possible complication and their management. Last question for you is, do you know what migration means of a LAMS? Okay, let's see if there's the answer. Okay, in literature it's quite confusing, misdeployment and migration, so probably we should standardize the definition of nomenclature in order to have the right, to definitely try to have a single way of defining complication, because it directly correlates with the management you should be aware of. And last slide, watch out to relative contraindications for LAMS positioning. And this is a case of a patient with an advanced adenocarcinoma with ascites and gastric outflow obstruction. Ascites is a relative contraindication for gastroenteral anastomosis, and as you can see, it can make the procedure more tricky, because as you can see, the loop was floating in ascites, so we need to give a second angines in order to reach correctly the loop. And I finished saying I hope to give you all the tricks to solve the enigma in this complication game, and thank you.
Thank you, Cecilia, for this amazing presentation. Are there any questions from the room? Also on the app?
Just a very quick question. When to remove the lamps? When?
I don't have the answer. It depends on indication. Now there's a problem in benign indications. Probably the answer will be always, because actually you don't know how long it lasts, the coverage of the lamps, and probably it's safer to remove the lamps and place double pigtail plastic stands that could last forever, probably forever and ever. But we don't have the answer. Usually are so sicky patients that I usually don't go to see them back, but we don't know the answer. For pancreatic fluid collection is the only indication that we know that probably is safer to remove it before the 4 weeks, but for other indication, I guess there is no answer.
And in your clinical practice, do you always use a double pigtail with the lamps?
No.
Okay, thank you.
Another question there from the back.
So Cecilia, you showed that maybe the guide wire is a false friend for the GJ. Do you think it is a friend or a false friend when we are performing choledochorduodenostomy?
I think that is a friend when it's preloaded, but not probably previously placed.
Okay, thank you, Cecilia. Thank you so much.
Now it's my pleasure to invite on stage Dr. Paraskevas Golfakis from Greece, who is going to talk about cystotomes, guide wires, and plastic stents. Thank you.
Good morning from my side. My name is Paris Golfakis from Athens, Greece. I would like to thank the organization committee for the invitation, especially Livia, Matteo, Piera, and Giuseppe, not only for the invitation, but also for the fantastic time that we spent here a few years ago. So my topic is less fancy than Dr. Binda's talk. I will discuss about cystotomes, guide wires, and plastic stents. And I would like to show you in the next few minutes, 10 minutes more or less, some tips and tricks regarding their use. The topic is tips and tricks, and actually, when we discuss about tricks, I am sure that no patient expects from us as endoscopists to appear suddenly a rabbit from a hat. What they expect is to perform a safe procedure, be efficient, and of course, both the patient as well as us want to do that in the most simple way. Starting with cystotomes, you see here the most common available in the market cystotomes, different companies and different sizes. They start from 6 French and go up to 10 French. But I would like you to keep in mind that the context of this device is not the same. We have the Cystogastro set that it's one-step procedure and they give us the ability to gain access in the cavity that we want to go directly and then enlarge the orifice with the cystotome. And we have simple cystotomes that provide us the possibility to enlarge the orifice, but we have to gain access using a classic FNA needle. So this should be something that we should keep in mind. Which one to use? That depends mainly on the size and the direction that you aim. If you want to drain, for example, a peripancreatic fluid collection and you want to place 2 double pigtail stents, that's common practice, then you should go for the Cystogastro set. Okay? It's either 8.5 French or 10 French, and it gives you the possibility to do the procedure fast and safe. There's no need for needle exchange, and it provides enough space to advance in the collection at least 2 guide wires. However, keep in mind that this can be a more complex procedure. Minimum 2 exchanges will be needed, and you have to cooperate adequately with your nurse in order to not lose your position. On the other hand, when we discuss about biliary drainage, for example, an hepatic gastrostomy or a rendezvous technique, then I think it's more simple and more easy to go for a simple kystotome. This is a 6 French kystotome, and the advantage is that it gives us better control of our movements. We can we have to use less space, and of course we have a less risk of leak. However, as previously said, this kystotome does not give us access directly to the cavity, to the point that we aim, and we should firstly perform a punction with the FNA needle and then exchange the needle for the kystotome. And in the recent European guidelines, this is what is recommended, to create the fistulous tract using this simple 6 French kystotome. Another point that, from my point of view, is important regarding kystotomes is current application. Which type of current? And the answer here is simple: pure cut, auto cut, the yellow pedal in our electrosurgical unit. You don't forget that never. But also, when do we apply the current? And this is something that I try to illustrate with schema. So this is our position. Initial position, we have the collection, we have the gastric wall, we have our kystotome, and the guide wire. Okay. I'm not very good at drawing, but I did my best. And this is what we should not do. Okay, we should not first push the kystotome and then apply current, because we risk to slip against the thick gastric wall and do not penetrate it correctly and lose our position. So this is something that we should not do. On the contrary, what we should do is first apply current, and at the same time, or some milliseconds after applying current, push the kystotome against the gastric wall. That will safely give us access in the gastric cavity, in the collection, I'm sorry, and we will terminate our procedure without any problem. This is the good thing to do. That goes for kystotomes. Guide wires. Well, you know all from your endoscopy rooms that there's a huge variety in terms of composition materials, diameter, the shape of the tip, and the stiffness, both of the tip and the shaft. And all this discussion is because we try to gain the best balance between friction and flexibility. Two main categories. On the left part, those that are more stiff with larger caliber from 0.035 to 0.038 inches, they allow us to better advance any device, and they can be accommodated with 2 needles up to 19G. On the other hand, those tips, those guide wires that are softer with smaller caliber from 0.018 to 0.026 inches, they allow us to entry in narrow and irregular spaces. They are also angle-tipped, and this can give us access in more difficult spaces. And for needles up to 22G, we can use a guide wire that measures up to 0.021 inch. But the problem is that all guide wires, especially the thicker ones, may present with a common adverse event. And this adverse event is the shearing of the guide wire during the procedure, and that happens mainly when we pull back the guide wire into the needle after having gained access in the periphery of the duct. So be careful. A common trick is that when you plan to drain a peripancreatic fluid collection, you use double pigtail, use long wires, and use either a matrix lumen catheter or a 10 French kystotome that allows you to advance in the collection 2 guide wires before you proceed to stent placement. And one trick that we use in my department, we always preload the second plastic stent on the second guide wire during the deployment of the first one, so as to gain some time. About biliary access, especially hepatogastrosome rendezvous, I think that we always should think about the needle that we choose. If you go for a 19G needle, okay, you can take a 0.035 guide wire, but remember, it shears easily, it may hamper the manipulation of the wire, and as I showed you, it can leave foreign bodies in the duct. A solution could be to move for the 0.025 inches guide wire that are less prone to shearing. On the other hand, if you use a 22G needle, you can go for a 0.018 or a 0.021 inch guide wire, but do not forget that this may sometimes be challenging to advance the rest of your devices. Sometimes they provide poor visibility and they are prone to kinking, and be careful, not all guide wires in the market are insulated against current. Here's an example. You see how easily we advance a 0.035 classic JAG wire in a 19G needle, but when we try to do the same with a 22G FMB, it's impossible. Okay, so always think of your needle. General tips, always train your nurse. Guide wire exchange may be very, very demanding, may be very challenging, and I would not recommend you to perform that with a novice nurse that starts her career in the endoscopy department. That may cause you lose a lot of time. Use the ankle guide wire if needed. It can be very useful for specific indications like hepatic gastrostomy and rendezvous techniques. And of course, always flash your needle after contrast injection. This will solve you many problems and will avoid sticking of the guide wire in the needle. The last part of my presentation about pigtail stents, especially double pigtail stents. These are the three main indications. Coaxial placement through lumps. Cecilia already made a comment about that. The most common indication is the drainage of peripancreatic fluid collections, pseudocyst or ward of necrosis, and they can also be used for pancreatic duct drainage. Available by many, many companies. It's always useful to be aware of their characteristics if they carry radiopaque markers, if they carry endoscopic markers, because these markers will facilitate the deployment of the stent and the formation of pigtail under fluoroscopic or endoscopic control. And of course, the most common diameter is that of 7 French that can also very easily be removed through the scope. Here are some photos of the plastic pigtail stents. I'm sure that you are all familiar with those. Some general tips, always pay attention when you load a stent. You should always use this positioning sleeve to be sure that you will not destroy the stent with the wire. These stents normally do not need any inner catheter in order to deploy them. You have to choose the right pusher, the right size of the pusher. If you take a pusher that is larger than the stent, then you risk that the stent will come in the pusher and will not be advanced. And if you take a pusher that is thinner, smaller than the stent, then you risk that there will be not enough force to advance the stent. And of course, for peripancreatic fluid collections, remember that 2 stents is enough. Here you see the use of this positioning sleeve in order to advance the wire in the proximal part or in the distal part of the stent. And when we do that, we move over the positioning sleeve in order to go through the second pigtail. Easy enough. And what happens if our stent has no endoscopic marker? No big problem. You take a simple marker, you create your own marker. Okay? At the proximal part of the stent, where it's what you expect to see during endoscopic deployment, and to know that you are ready to remove the wire and create the pigtail loop. And with that said, I would like to thank you very much for your attention.
Thank you, Paris, for your very clear presentation and very pointful presentation. Do you have any question?
Yeah.
Thank you, Paris. Wonderful. I have 2 questions. What do you think of access needle? So needles with blunt ends when you remove the stylet for some indications. And the second one is when you use plastic stents for collections. No, I think you opt for long-term indwell of these stents. Marianna has done a wonderful trial on that. Would you opt for polyethylene stents or some softer stents like we use the Solus as, for example, for that indication? Are you afraid of harder stents to create harm in the long term?
Excellent questions. For the first one, of course, we can use access needle. That's there's no problem. For the second question, Giuseppe, it's I can get your point, but actually we don't have any data supporting that harder plastic stents could be responsible for a high rate of adverse events in the long term. And in our study published a couple of years ago with 164 patients with a long term of a plastic stent placement, the main complications were not related to the stent, actually. So it would be interesting to search the literature. I'm not aware of any study looking at that, so I cannot give you a more precise answer.
Thank you. Other question? I cannot see. I think no. No? Okay. Thank you so much, Paris. And now let's move rapidly to the last presentation. I know that Gian Enrico has the hands-on session and he has to run there. So the last presentation is, of course, on tricks and devices of radiofrequency ablation techniques.
Good morning, everyone. Thank you, Olivia. Thank you, Matteo, for the kind invitation. It's great to be here today. We'll talk about radio frequency devices, and in particular, we'll see devices used to perform EOS-guided radio frequency ablation and devices used to perform ERCP or biliary RFA. These are the main devices for EOS-guided RFA that we will see today. In particular, we will focus on the StarMed system that is the most commonly used and studied. The StarMed system consists of a 19-gauge monopolar needle, a dedicated generator of radio frequencies, and an inner cooling system with a water pump. So the water pump circulates a chilled saline from here through these tubes to the end of the needle in order to make heat dispersion. And this is the rationale of having an inner cooling system. It's because it provides a more homogeneous, a more round and bigger area of ablation when performing these procedures. This is the generator. You can see with the small button, you can choose the modality. There are several modalities. For EOS RFA, we use continuous mode. And with the white knob, we select the power in watt. We usually choose between 20, 30, or 50 watt, depending on the lesion target. And another important thing for this procedure is the needle. It resembles a common FMB needles. It's a 9-gauge needle. The only difference, it has an exposed tip at the end. So here it's where the tip delivers the energy and heating is created. It comes in, it's commercially available in different size, and this is important when you decide the size of the tip basing on your target lesion. The most commonly used are the 5, 10, and 15 millimeter exposed tip. And as you see, basing on the exposed tip length, on the power that you use in watt, and on the ablation time, you can produce different ablation area, and this obviously depends on your target lesion. This is what happens when you start ablating, when you start your generator. We have a rapid increase in the power, in the watt, that reaches a plateau at the value that you previously set on your generator, as we just saw. The impedance, it's initially low, and as you complete the ablation, as the tissue is ablated, when the tissue is completely ablated, you see a marker increase in the impedance, and at this point, the generator automatically reduces the current and the delivery of energy. To make it more clear, I'll let you show it on the generator. So with this button, you start the ablation. Power reaches the preset value of T50. The impedance is initially low as the tissue is being ablated. Depending on also the tissue quality, the tissue hardness, it may take longer or shorter, and also depending on the lesion size. At one point, the impedance starts to increase exponentially. This is the point where you can stop your ablation, that meaning that the target tissue is being completely ablated. You will see here shortly, here it goes. So it increases dramatically, and you can stop the radio frequency. And this is the EOS vision. So same thing, you put your needle as usual at the far side of this lesion, and you start the ablation, you start the generator. What you see here is some white microbubbles, some hyper-echogenicity that starts here in the site of the needle tip.
what you do is you perform a slow pullback of the needle in order to cover all the area of the lesion. And the appearance of these white bubbles here corresponds to the increase in the impedance. And at this point, you can stop the ablation. This is a second device for US RFA. It's the ABIB probe. It was produced by EMcision, now was acquired recently by Boston Scientific. It's a 1 French wire. It comes with an active tip to 10-20 millimeter. Again, it's a monopolar device. It doesn't come with a dedicated generator, as we already saw for the StarMed system, but can be used with any electrosurgical units. And it's used as a through-the-needle device, so it can be used through 19-gauge needles. This is another interesting device. This is a courtesy of Sabrina Testoni, who studied and this device for radiofrequency. Again, it's a needle type device. It's a 14-gauge needle. It's a bipolar device, so differently from the StarMed system. And the other difference is that it used as a cooling agent not the saline but carbon dioxide that is more efficient. It requires a dedicated electrosurgical unit and an additional unit that substantially controls the flow of carbon dioxide through the device. And then we have the ERCP guided radiofrequency ablation devices. There are the counterparts of what we just saw for US. So we have a device by StarMed. It's called the ELRA. It's a catheter, it's a probe, 7 French in dimension. It's a bipolar electrode, so it doesn't need grounding pads. It comes in different size, and this to help the clinician to choose the adequate one based on your target. As a temperature sensor, this is because differently from what we saw from US, this device that again works with the dedicated radiofrequency generator, the Viva Combo we just saw, works with a different modality that is the temperature mode. In particular, the ideal ablation temperature for obtaining our best results is around 80 degrees. So this is what we set on our radiofrequency generator, and the power it's usually much lower in comparison to US RFA, usually around 7 to 10 watts, and ablation is usually very fast, between 19 to 120 seconds. And in this chart you see the principal differences with the second ERCP device for RFA, which is the ABIB Endo HBP probe. Now, as I just told you, was acquired by Boston Scientific. It comes in just one size. It has 2 different electrodes of 8 millimeter each. It doesn't come with a dedicated generator, but again it can be used with any electrosurgical unit, and the rest is pretty much the same. I'm going to finish with just 2 cases, courtesy by our colleague Andrea Tringali. This is a case of radiofrequency ablation for a SAMS ingrowth. We don't particularly like this type of procedure, but just to let you show. This is the ingrowth. Here, the placement of the radiofrequency device. This is the result at the end. And the second one is the treatment of intraductal extension of ampulloma. The first part of the video, you see classic ampullectomy with the snare. So In some cases, we perform radiofrequency ablation when we observe intraductal extension, limited intraductal extension with these devices. In some seconds, you will see the insertion of the, in this case, was the StarMed device inside the biliary tract. Here it goes. You see the electrodes, you can see it endoscopically, and then the generator is activated, and you see an area of edema and discoloration as the radio frequency is being performed, and this is the result at the end. And this was my last slide, so thank you for your attention.
Thank you, Gianenrico. Very nice presentation. I think we have time only for one question, one brief question. Do we have one? Are you hungry?
Yes.
Okay. So if there are no questions, maybe we can go to the lunch, and
thank you.
We will meet here again at 2:30, 2:30 p.m. Okay.
So good afternoon, everyone. I invite you to please take a seat because we're ready to start the afternoon session, which is going to be more on the interventional side of EUS. And I'd like to invite on stage the discussants of this afternoon session, Dr. Vanella, Dr. Perez Cuadrato Robles, Dr. Martinez Moreno, Dr. Tamburrino. Please on stage. I'll leave to you the moderations of this session as also the discussions. I'll stay on stage just for the questions from the floor.
Welcome everyone to this session. This is a very important session because it's thought to be very interactive, and you will have the possibility of asking questions for all the topics we will be discussing, with a very large window coming from the biliary drainage to gastric hotel obstruction and also the ablation of pancreatic lesions. So you know all my colleagues here, so Dr. Belén Martinez Moreno and Giuseppe Vanella, myself, and also Domenico Tamburrino. And we will be starting by the talk from Belén, who will be presenting biliary drainage.
So, good afternoon. I would like to thank the organizing committee for the kind invitation. Today I'm here to talk about biliary drainages. And when I think about learning biliary drainage, I compare it to mountain climbing. It can be a great solution for our patients, but it can be hard and it can be very risky. And this afternoon I will try to show you how to deal with it. So we all know that we have 3 different access routes when we want to drain the biliary tree. We can access an intrahepatic duct, we can access the extrahepatic duct, or we can drain the gallbladder. But which procedure should we perform in each case? Well, to answer this question, we have to consider some features. First of all, who is our patient? Does he have a native anatomy or an unaltered one? Is there any stricture? Or, of course, has the patient a benign or a malignant disease? And ideally, we should base our decision in the existing evidence, but the truth is that the evidence now is very poor in some topics. But we have also another local features while we are waiting for more data, like local expertise, personal preference, and the time that we have to perform the procedure that will play an important role also in our decision. So I'll try to show you my mental planning when I trying to decide which route I'm going to follow. First of all, is the papilla accessible? As well as, is there a stricture proximal to the papilla? Because in these cases, we are not going to be able to perform an ERCP or a rendezvous, but we have a hepaticogastrostomy, choledoduodenostomy, and we can also drain the gallbladder. On the other hand, if the stricture is located at the antrum, pylorus, or first part of the duodenum, the only option that we will have is to perform a hepaticogastrostomy. And more or less, the same applies when the anatomy is altered, but also in these cases we have some more specific solutions, but I don't have time to talk about everything, so I'm sorry. But the key here, I think, is to have more than one plan in mind, because we have to be quick, and we have to be able to change our plan if it's not working. And here, in these tables, summarize the scenarios where we can use each of these procedures. this is nothing new, I think, but I think that an interesting question could be, should we drain under US guidance only after a failed ERCP? What do you think? Let me show you one case report. Imagine you are doing a US in an unresectable pancreatic tumor patient and with jaundice. And you are performing the US to perform a FNA or FMB, and you see a huge dilated CBD with 26 millimeters, and that the tumor is affecting also the duodenal wall and the ampulla. And an ERCP was planned, but after these US findings, what would you do? Would you try an ERCP as was planned before, or would you change your mind and perform an US biliary drainage? I think you can vote. Okay. I mean, this is not a right or a bad answer. It's just, I mean, I was just curious. You are changing your mind? Okay, more or less 50-50. Well, I have to admit, I would probably change my mind, and I would directly to perform an US biliary drainage, probably a choledochoduodenostomy in this case. But there's not right or bad answer. But the thing is, there is increasing data that show us that the US biliary drainage might become a first option in some situations. For example, as these two very nice randomized trials from published last year, and they compare a choledochoduodenostomy with lumps versus ERCP, and both came to the same conclusion. They didn't see differences, significant differences in stem patency after 1 year, and they suggest that both options could be a primary options in unresectable patients, because they were all unresectable patients. Well, now, but how can we perform all these nice procedures? Well, from the anatomical side, we have two different types of biliary drainages. We have the transmural way, when we are creating a new biliary path, okay? And we have the guide wire assisted way, when we work over a guide wire that we inserted under US view, but that's all. That's where the US finished. Let's see how can we drain the gallbladder or the CBD with a hot lens. Well, Cecilia explained us before very, very nicely all about the hot lamps. I just want to repeat that the main advantage of the hot lamps is that we have all-in-one device. We don't need to do exchanges, and this we don't also need to perform a dilation of the tract. And this is very interesting. We are draining the biliary tract because this will lead to less leak. And if we want to climb high mountains, we have to start with the lowest hills. And for me, after pseudocyst drainage, that means the gallbladder drainage. US gallbladder should only be drained with a hot lamps, and I recommend to have a preloaded guide wire. And what can we do if the gallbladder is not very distended? Well, we can first puncture the gallbladder and distend it, as you can see in the pictures. And maybe patients with percutaneous drainage are the best first cases, are the best option, because we can distend the gallbladder carefully, but it gets easier to perform the drainage. Let's talk about choledochoduodenostomy. This is a very nice dilated CBD, almost 2 centimeters. We can see the catheter of the Axios coming inside of the CBD. We release the distal flange, we throw the catheter, and then we release the proximal flange. And now we can see the bile coming out of the lamps. Some tips that I can give you. I recommend always to perform it with free hand. It's very, very important. And also with a preloaded guide wire. But that we can advance, once we have deployed the distal flange, I would recommend to advance the guide wire and never lose this guide wire, because this can rescue and risk these procedures. And regarding the coaxial pigtail, well, you have these preliminary results of the bumpy trial, and where they saw that there was a significant less recurrent biliary obstruction in the group where they had a coaxial double pigtail inside of the Axios. So we are waiting for the final results, but I think that in the future we will recommend a coaxial pigtail in the cholecystectomy. And which lamps should we use? Well, I recommend the smallest ones, and be careful because with the diameter of the CVD, because we need a minimum space to release to be able to release the distal flange. And performing a CDS and with CVDs under 15 millimeters can be very risky, so be very careful. So let's talk about performing a hepaticogastrostomy or a colocodonostomy with a biliary stent. Then basically the steps are: we have to puncture the duct, we have to advance the guide wire. This is a colocodonostomy. We dilate the tract, in this case with a 6 French cystotome, and we deploy the stents. These are the basic steps. So for the puncture, we have to perform it with a 19-gauge needle. We aspirate the bile to confirm that we are inside of the duct. We inject some contrast and saline after that to clean and to be able to advance the guide wire more easily. I like it in this way. And for the hepaticogastrostomy, I don't really care if it's the segment 2 or segment 3. The only important thing is that you are sure that your endoscope is below the diaphragm. That's where we have to be careful. And it's recommended a distance between 2 and 3 centimeters between the gastric wall and the duct, so that prevents the bile leak. And then we have to advance the guide wire. It should be a long angled 0.025 French. And in the choledocodonostomy, we have to direct the guide wire up to the ilion, and the hepaticogastrostomy down to the duodenum. But the steps are, as you can see, the same. After that, we have to dilate the tract, and you have to be careful, because once we dilate the tract, we have to complete the procedure. Because if we don't do that, the patient will develop complications, will develop biliary liquids, and then we are in trouble. So we have to complete the procedure. We can do it in 2 ways. When you use electrocautery, cystotome is recommended over the needle knife, because as you can see in these pictures, only the cystotome is following the exactly way as the same as the guide wire. And for the mechanical dilation, there are a lot of devices on the market. You can find your own favorite one. And after we dilate the tract, we have to insert a stent. In the choledocodonostomy, it has to be a fully covered biliary metal stent. I prefer those with flaps or who are flared, to prevent the migration, but if you don't have one of them, you can maybe put a clip to anchor the stent to the duodenal wall. And in the hepaticogastrostomy, you can also use a fully covered stent, but only in palliative patients we can use a partial cover stent, because we don't want to exchange this stent or remove. And be careful with the release technique in the hepaticogastrostomy. We should release the distal part of the stent under X-ray, and in the proximal part of the stent inside of the channel, and then while we are removing the scope, we are pushing the stent out of the scope, as you can see in this video. And why doing this in that way? Because then we are preventing the can design that develops when there is a gap between the stomach and the duct, and this can lead to misdeployments of the stent. And let's talk about the guide wire assisted procedures. The antegrade stenting is not very different from a hepaticogastrostomy. The steps are basically the same, except that our target is very far from our scope, and then we are not going to be able to transfer the force in the same way. But we can manage this issue using a stiff guide wire or maybe a thin catheter, a 6 French catheter stent. And we should know that if we achieve a good antegrade drainage, maybe it's not necessary to leave also a hepaticogastrostomy stent. And some words about the rendezvous. In the rendezvous, we have to puncture the extrahepatic or the intrahepatic duct and advance the guide wire through the papilla. This is the main principle. But to puncture, for the puncture, if we are performing the puncture in the CVD, I would recommend the 22-gauge needle over the 19-gauge needle, because it will lead to less liquids, bile liquids, and we prevents some complications. And about the guide wire, advance as much guide wire as you can. And maybe other tips that you can use, have more than one guide wire ready. Notice that the scope direction is very, very important, as you can see in the picture, to achieve that the guide wire can cross the papilla. And you need to be patient, because crossing the papilla with the guide wire is sometimes very tricky, and you also will need a good assistant. Once for the next steps, we need a duodenoscope, and for the cannulation, we can do it in a parallel to the guide wire, over the guide wire with the monorail technique. This is with we can see how we can do it in our unit with a self-made monorail sphincterotome. And with the sphincterotome, we can ride over the guide wire, crossing the papilla and inside of the channel very easily. But if these techniques don't work, maybe we have to grasp the guide wire, which normal. It's very, it's a nightmare sometimes. And I also have a last clinical case. We have a palliative patient with jaundice, and but we are not able to perform a ERCP because there is the second part of the duodenal stricture. And we perform the ultrasonography, and we can see 18 millimeters common bile duct, severe dilation of the intrahepatic bile ducts, and a distended gallbladder. Which approach would you take? Would you perform a choledochodonostomy, hepaticogastrostomy, extrahepatic rendezvous? Would you dilate the stricture and try an ERCP, or would you drain the gallbladder? As in the question, there is not a good or a bad answer. These all are possibilities that we could do. Okay, I think the majority of you would perform a choledochondrostomy. I will perform a hepaticogastrostomy, and I will explain you later why. But how would, and now imagine that this patient develop gastric outlet obstruction symptoms. So we have the biliary stricture and a duodenal stricture. How would you treat it? Would you perform a surgical gastrojejunostomy, Eus gastrojejunostomy, duodenal stent, nasoenteral tube? So now I think we all agree more or less. We will perform a Eus gastrojejunostomy, most of us. I will also do that. And just a few words about that, because I'm sure Gabriele will talk us about these questions later. But we have this nice study that when with patients with biliary and gastric outlet obstructions, and one of the main conclusions is that enteral stent combinations had the worst outcomes, and that's what we should avoid in these cases. And that's why, in this case, I would not perform a choledochondrostomy, because if we already had a duodenal stricture, choledochondrostomy in this study didn't show good results. And that's all. I hope I show you how hard it can be, but it can be also very nice and very resolutive. So I think it's very worth to know these techniques, but be prepared to solve the complications that will occur, of course. Thank you.
Do you have some question for Belen?
I have a question, not for Belen, but for the audience. For D2 stricture, would you go for surgery? I wouldn't go for surgery. I am surgeon. Well, my life has changed since we started doing this kind of drainage, because we save money when we also reduce patients' hospital stay. After a gastrojejunostomy performed via US, we have 2 days patients recovered, and after gastrojejunostomy performed surgically, we have at least 4 or 5 post-operative day in the hospital. So I would go for surgery in this kind of patient.
So there is a nice ongoing study. This is the eating study, and this is the main objective is to compare surgical gastrojejunostomy versus US-guided gastrojejunostomy in fit patients. I'm talking about surgically fit patients, and this would be very interesting to know these results.
I have a short question. So you are still speaking about choledochondrostomy performed by tubular stents and by LAMS. So is there an occasion where you prefer one or another, or are you switching to LAMS because LAMS are getting more, let's say, spread? Or
So I have to admit that we are performing in very rare cases codonostomy with SEMS. If the TBD is very dilated, over 16 millimeters, then we go with the lamps. But in other cases, we prefer the hepaticogastostomy.
And maybe another question from my side, if there is no more questions from the audience. As you have very well explained, Belen, it's sometimes somehow very difficult to decide the therapeutic algorithm in these cases because we have a lot of different options you have presented. So in your center, how do you decide? You have a pluridisciplinary discussion, you are deciding from your side in your service, you have a teamwork with the surgeons or radiologists to decide which approach will be the most convenient in each case. How do you move forward?
Well, before we have the patient in the room, I like to have more or less we have to know the decision about the patient. If this is a surgical, if there's going is this a palliative patient or borderline, or because it's very important. But once the patient is in the room, then we decide based on the findings that we find. Because if the patients change, the images change from a CT that you had 5 days before, now everything has changed, and then you have to change your decision. And I think, yeah, that's the right way.
Okay. We have also one question from the audience.
Yeah, it's about guidewires in hepaticogastrostomy, I guess. So when you are going to release, it's about guidewires in hepaticogastrostomy. So when you are going to release the lumps, even if you have to use the small caliber wire, do you always switch to a larger 0.035 when you are releasing the stent, or you just go for the 0.25, for example, for hepaticogastrostomy?
If it's, yeah, we very rarely change the diameter of the guide wire. Only if there is maybe the way that we need to change. So it's like an angle that maybe a stiff guide wire will help you with this angle. But
maybe I can add something from my experience. I don't know how are you doing in this setting, because this is a very interesting question. Sometimes when you have performing several punctures with the 19-gauge needle, you can peel the guide wire. And so afterwards, once you have your cystotom in, sometimes the guide wire is damaged, and should be a good idea to change the guide wire, not really because of the size, 25 or 35, but because of a new guide wire with no peels or no damaged areas. So that should be interesting. And also, in my experience, when I'm doing anterograde drainage particularly, I like stents with 8 millimeter with an introductor of 6 French. And sometimes the SEMS with a 6 French introductors need to be used through 0025 guide wire and no 0035. So this is also depending on the stent you are using, because not every stent admits all guide wires.
Okay, so we move on. Now, Giuseppe Vanella, gastric outlet obstruction. Pepe, the floor is yours.
Thank you. Good afternoon. So the topic is gastric outlet obstruction, how we treat these patients, and why we are nowadays endorsing use-guided gastroenterostomy, and how we perform use-guided gastroenterostomy. So first question, why? So from old randomized trial, we already knew that endoscopic self-expandable metal stents had better short-term outcomes, of course, lesser invasiveness, but a very high rate of recurrences during follow-up, whereas surgical bypass was better in the long term, however, at the price of a higher invasiveness. Nowadays, we have use-guided gastroenterostomy, so a surgical, a bypass similar to surgery, but made by endoscopists, thanks to the advent of electrocatheter-enhanced lumen-opposing metal stents. And what we find in literature, this is one of the many meta-analyses on this topic, when compared to surgery, use-guided gastroenterostomy has the same technical and clinical success, but of course lesser invasiveness, shorter hospital stay, shorter time to refeed, and this is the larger retrospective study on this comparison. Again, you see shorter time to clinical success, shorter time to chemotherapy, shorter length of hospital stay, reduced adverse events when compared to surgery. What about the comparison with endoscopic SEMS, self-expandable metal stents? In this case, we have a trend towards higher clinical success and, of course, a reduced rate of reinterventions and recurrences of obstructive symptoms. All this literature comes from retrospective series, but nowadays we are starting to see prospective data. This is the Spanish study, single arm. This is our experience, a prospective study on our series of use-guided gastroenterostomy with a comparison with enteral stents, again showing higher clinical success of use-guided gastroenterostomy. So these patients seem to have a better nutritional outcome, let's say, a better feeding experience, let's say, and of course, a reduced rate of recurrences and reintervention during follow-up. And nowadays, we have also randomized data on this procedure. So this is the DRAGU trial, again showing a trend to higher clinical success, but of course, reduced rate of recurrences and reinterventions with a significantly higher 6 months patency for use-guided gastroenterostomy. We are still dealing with recurrences and not with patient-reported experience. So we are now running a study on this. This is a prospective study endorsed by the Pancreas 2000 program and the EPC, so you are welcome to join the study. If you treat this patient, we are interested in patients with pancreatic cancer and malignant gastric obstruction, candidate to either procedure. This will not be a randomized study, but in either enteral SEMS, use-guided gastrojejunostomy, or surgical gastrojejunostomy, these patients will undergo prospective observation, and we will try to register some key outcomes such as quality of life, chemotherapy tolerance, body composition, and nutritional status. And this is another use of use-guided anastomosis. They can be of help in performing biliary interventions in post-surgical anatomy. This is the simpler one, so drainage of afferent loop syndrome, but we have also the so-called use-directed transenteric ERCP, so you can recreate a connection between the gastric pouch and the remnant stomach in a Roux-en-Y gastric bypass to perform a standard ERCP, or you can create a connection between the biliary loop of a Roux-en-Y hepaticojejunostomy and the stomach or the jejunum to perform again biliary interventions in Roux-en-Y hepaticojejunostomy. You will see a couple of examples during this Euro-US live. And how do we perform use-guided gastroenterostomy? Of course, this is a new procedure. This is not, this is what we do in Milan. Probably you might have different experiences, but in a new procedure, we try to learn from our cases through prospective data collection by reviewing our videos. So this observation became notes, and then we try to standardize a checklist for use-guided gastrojejunostomy. So I will show you our checklist, but you can find also these steps in the previously mentioned publication, recent publication in gastrointestinal endoscopy. So this is the so-called WEST technique, wire-led simplified technique, that we have named together with our friends of Leuven and Amsterdam. But I was happy to see that these steps are also shared by other experts. This was an abstract presented by the Spanish group at last UAG week, and you can see in green, actually, these are all the steps that we share with the Spanish group, some small difference in small parts of the procedure, but let's see. Some data from the ESG guidelines. So we do perform prophylactic antibiotics during the procedure, and we do a long course of antibiotic in presence of ascites. Of course, you need fluoroscopy to perform this procedure and CO2. We can discuss about airways protection, but we do so. And of course, you have to use electrocautery enhanced luminapose metal stand, better the 20 millimeter, the largest you have, let's say. One very important step is the orojejunal tube. We place a guide wire with a sphincterum over the stricture, and we pass a 8.5 orojejunal tube, and we aim that the pigtail of the orojejunal tube is in the first loop after the trites, and the aim is to have a controlled distension of the jejunum, to stabilize the loop, to identify the loop under endosonographic guidance, and to confirm correct lamps placement by contrast injection, and in case something is wrong, to exclude clinically significant enterotomy with contrast injection. So we want to see these. We have not insufflated any liquid for the moment, but we want to see the orojejunal tube inside the loop after the trites, and then we can start our inflation of the loop. We use saline mixed with indigo carmine, and you can see the perturbation of fluid injection inside the loop, and this is a sign of proximity to the pigtail of our orojejunal tube, in case you cannot see the tube itself. We aim at an oblique course of the loop, because the important thing is not the diameter, but the important thing is the operative space you have for releasing your lamps and the distance you have between your gastric and jejunal wall. So, as for example, this is obviously not a good window for use-guided gastrojejunostomy. You can see a transverse direction, not enough dilated loop, an excessive gastrojejunal distance. When you have identified the trites, a clockwise rotation probably will bring you towards the jejunal side of the trites, and you, of course, want to go in the sense of the peristalsis, and then you are ready to release your lamps. So an electrocautery enhanced lamps release the free end, and what you want to see is the boiling water effect, so the effect of electrocautery enhanced tip on the fluid inside the loop. And then you are ready to advance your catheter. You might lose the acoustic coupling with the tip of the catheter, but the important thing is that the walls of the jejunum remain there, remains attached. And then you go for your lamps release as in any indication, so the release of the distal flange upon endosonographic guidance. Then you retract your lamps, and what you want to see here is this. So you want to see the catheter inside the fluid-filled loop and the jejunal wall surrounding the lamps. And then you go for intrachannel release of the luminapose metal stent, and then you push the lamps outside your operative channel by taking some distance to the wall, and you want to see, of course, the blue coming outside the lamps into the stomach. In this case, as for example, you can inject some contrast from the orojejunal tube, and if you see contrast coming through the lamps without any leak, that means that you are inside and you have performed the correct placement. We usually dilate the lamps, but this is not standardized. I will not go into this. You know that this is not the only technique for performing use-guided gastroenterostomy. There is the EPAS technique, so using a double balloon, and you will see a couple of cases during the live streaming of Euro Eus. But the problem with the EPAS technique is that you don't have a through-the-scope catheter, so it's a bit cumbersome, the placement of that double balloon. Probably the future might be this device, so a through-the-scope double balloon with a detachable hand, so you can advance this double balloon as it was a normal catheter. And of course, if you can create a sort of cavity with controlled distension, this becomes like draining a fluid collection. We have misfortunes, of course, in this procedure. We have collected also the misfortunes of use-guided gastroenterostomy in our publication. So contraindications, massive ascites, linitis plastica, multiple carcinomatosis. And we have adverse events, but this is not the topic of this lecture, so we will see you on Friday because we have a session on this. The most important thing, I always say that if you are performing therapeutic EUS, you need to be prepared to face adverse events, and you must rely on proficient interventional radiologists and surgeons in your hospital, and above all, you need to have shared written path for these events, because of course sometimes you need their help, because the important thing is to have a multidisciplinary vision of what is better for the patient. So in conclusion, use-guided gastroenterostomy is safe and effective in experienced hands. Training in high-volume institutions is fundamental. We should aim for standardization and reproducibility of the technique. The availability of a jejunal catheter makes a difference. It's fundamental to read endosonographic signs of correct or incorrect placement. Proficiency in endoscopic management of complications is required. Misdeployment is not always a failure. We will see some cases during Euro-US. Above all, the surgeon is not an enemy. If your procedure fails, a conversion to surgical bypass is not a failure, at least for the patient. So I would like to thank you for your attention. I would like to thank my friends in Leuven and Amsterdam for our collaboration, and the whole team here in Milan.
Thank you, Giuseppe. Do you have some questions maybe from the floor, from the audience? If not, I have maybe two questions. The first one is how do you proceed when you don't have your stenosis or duodenal stenosis cannulated, and so you cannot place this catheter? No, this is a difficult situation we are actually facing not in a minority of cases, but that happens. This was the first one, and the second one is there are a lot of people very interested in developing this new mainstay in the treatment of gastric gallbladder obstruction. Which cases do you think should be the best for starting? Which cases, or there is a specific case or a specific indication or situation where you think is easier to perform the gastrojejunostomy to start doing this procedure? Because this is a very common question within people who are starting with this.
Okay, the second is a bit tricky. We can discuss that. The first one, okay, you are right. It's a rare event that you cannot pass the stenosis. It is I think once or twice a year in our institute. But when it happens, you have an advantage over enteral stent, because you can still inject your loop with a 19-gauge needle and perform the procedure as well as you will perform an EDI, as for example, or an edge. So in those cases where you cannot pass through the stenosis, probably the best thing is to try to find the trites, find the first jejunal loop, inject with a 19-gauge needle, distend the loop, and go on with your use-guided gastrojejunostomy. The second one, I don't have a question. Probably I would avoid some cases in my beginning. I would avoid patients with ascites. Ascites is not a contraindication, but makes things much more difficult. I would avoid resectable patients at the beginning, because you have you have to do an agreement with your surgeons where you want to place the lamps, and not always at the beginning you are able to find that exact loop and not just one loop. So I would avoid some cases at the beginning rather than choose one.
We have a question from the app. Is there still a place for surgical gastroenteral anastomosis in patients with pancreatic cancer?
This is not a question for me. This is a question for
Mimmo.
for many.
Well, I think this is a good question. To be honest, I don't think there is still an indication for surgical gastroenteral anastomosis. Why? Because, I mean, we try to also perform EUS gastroenteral anastomosis also in patients who had chemotherapy and then were treated with surgery. And we didn't have any problem to resect the patient, to take out the lumps, and also to perform a good, lymphadenectomy and also a good anastomosis on the enteral tract. So it is very difficult for me to say that there is no indication for gastrointestinal anastomosis via surgical rather than via endoscopy.
And Giuseppe, what do you think about the benign indication for a gastrojejunostomy? How did you manage the follow-up, or in these patients?
That's a really nice question. We have performed a lot of malignant gastritis obstruction with the use-guided gastrojejunostomy. We haven't performed many benign cases. Of course, that needs to be a real unfit for surgery patient, and in that case I would program some periodic follow-up, because we don't have any data about long-term indwell of lumps. Of course, as Cecilia said earlier, we don't have a reassurance about the silicone covering of the lumps, so they actually become uncovered stent after a while. So I would plan a revision of these stents at least at 12 months. Yeah, 12 months, it's a bit long as a period to revise a lumps.
Thank you. Thank you.
Thank you.
Now, Enrique Pérez Cuadrado will present the last talk, ablation of pancreatic lesions.
Thank you very much, everyone. So I will introduce you a different topic from the two topics we have seen before, more regarding the ablation of pancreatic lesions with new techniques and devices we have already been discussing this morning, more or less. As you know, we have different strategies of ablation in pancreatic lesions for different type of cystic or solid lesions. We have some evidence in the literature regarding the US-guided ethanol ablation, also the intratumoral drug delivery, but the most promising therapy nowadays is mostly the radiofrequency and the US-guided radiofrequency, so I will be mostly focused on this one. As you know, US have led to earlier detection of non-functional pancreatic neuroendocrine tumors, and particularly small ones, particularly smaller ones than less than 1 or even 2 centimeters. US-guided ablative techniques have been applied to an overgrowing spectrum of pancreatic pathology, so this is already known therapy, and this is having more and more place as a role on this particular setting of pancreatic neuroendocrine tumors or solid or cystic lesions. Given also, this is known that this is somehow unpredictable, the malignant potential is some selected cases and selected patients with non-functional pancreatic neuroendocrine tumors, and particularly those presenting with small lesions, less than 2 centimeters in size. So at this moment we have the US-guided radiofrequency, a promising technique with not a lot of studies, but more and more evidence-based data in the last years that I will be presenting. I will not go into the details regarding the different devices we have nowadays, because this has already been presented during this morning, but you know that we have a specific dedicated needles with a water cooling system to perform the radiofrequency ablation with a very similar technique compared to the US FNA FNB we are used to. And we have more and more studies with a prospective fashion methodology and also systematic review meta-analysis trying to analyze overall the clinical success of the technique in these small lesions, most of them solid neuroendocrine tumors, or also in sub-studies cystic lesions or IPMN or small IPMN. The pooled complete radiological response in a recent meta-analysis of 11 studies was very high, 87% of cases, as you can see here on the forest plot on the right, with very homogeneous results within all studies. We know that this can be also interesting to analyze the clinical factors related to this clinical success, and again, size is important. In this setting, tumors from until 20 millimeters in size will respond much better with better outcomes in terms of clinical response. When we are talking about clinical response in the literature, most of the times it's either a functional tumor, neuroendocrine tumor, and particularly insulinoma, because this is the most common situation we have been analyzing in the literature, who is responding, so there is no more hypersecretion and patient will not have hypoglycemia, or a complete radiological response, either with a disparition of the lesion or a complete necrosis in the area we have done the radiofrequency. These are the two ways we have been measuring in the literature the response of this treatment. Particularly for insulinoma, as you know, this is a most interesting setting for these patients because most of them, they will be presenting with a small lesion and functional insulinoma, letting this therapy possible, because as I have previously said, this is most thoroughly to be used for small lesions. And again, the results are quite good, with a clinical efficacy of more than 90% of cases compared to surgery, so with no relatively significant differences in clinical efficacy. But on the contrary, we can see also down that the relapse rate is much higher compared to the surgical approach, so 17% compared to 0. At the same way, we have other features at hospital stay, at the follow-up. We can only also analyze, but probably the most important will be to analyze the adverse event clinical efficacy and the relapse. So the US RFI in the different studies in the literature seems a good option for benign insulinomas, even if this is true that the long-term outcomes are not very, very well known for the moment, but we can state that there is a clinical resolution of hypoglycemia in most of cases, and a long-term follow-up for sure will be very important to have more data and solid data regarding this outcome. Usually, most of the studies, they are doing a more or less structured follow-up in 6 months. We are at MRI and endoscopic ultrasound, and the results are very variable with a large window, but more or less the outcomes are high, as we have already presented. Even if this is true that the settings, and this is a technical point, but the settings of the RFI sometimes are not very well known regarding the different indications coming from the cystic lesions to the neuroendocrine tumors, particularly insulinoma, or even metastatic disease. Here we can see at this point the different indications we can also see in the literature coming from, I have said, the non-functional tumors in this study with 48 lesions, non-functional neuroendocrine tumors, functional tumors, metastasis, and also IPMN. This is a less frequent, I would say, indication with probably less performant outcomes in general, but for the moment we have small series or small prospective studies, so it's difficult to conclude about the outcomes in these cases. But overall, the complete response you can see that is about 80%, 70% in cystic and solid lesions. So the US ablation of pancreatic cysts also provides acceptable rates of complete resolutions, about 60 to 80%, with low incidence of severe adverse event. And this is also a very important point, because when we are comparing with the gold standard, so as you know, surgery, it's important to understand the adverse events and the relapse rates from one side to another to decide the better approach in these cases, given also that we have much more data, of course, for surgery, and these are all initial studies or pilot studies with prospective data and not a lot of randomized fashion manuscripts or published studies at this setting. We have this last work from a French team from Lyon, stating that the adverse event can be low in this subgroup of patients undergoing US RFI, with a 22% rate and 0% mortality. But this is even more important, the factors they have analyzed related to these adverse events, because this is something not very general, but mostly related to very specific characteristics. In this study, again, of 100 patients who underwent US RFA with different tumor size and different clinical presentations, there were some contraindications for surgery. 5 patients also underwent previous surgery and 2 previous US RFI. So there are also patients not fitting for surgery in all these studies. Sometimes we are needing to perform several sessions and several shots during the RFI, depending on the size of the lesion, until we have some bubbles and everything is completely covered, to be sure that the whole lesion is treated. This is mostly seen during the US examination, but the most important point I would like to highlight here is that the proximity to the pancreatic duct is completely related to adverse event. And this is a very important point that can be easily, more or less easily evaluated during the previous diagnostic US or MRI before deciding the radiofrequency treatment of these patients. Because when the main pancreatic duct is less than 1 millimeter, in other studies is 2 millimeters, the risk of adverse events is much more important, and all the other factors did not have a statistically significant difference in these areas. So again, when we are also analyzing the factor related to clinical success, we have seen the overall cystic lesions are not giving very, very good outcomes, even if we are discussing about a clinical response, about a complete radiological response of 60%. But when we are going to all neuroendocrine tumors, this outcome will be higher. And also the size, as we have said already several times, of less than 20 millimeters is a very good predictor of clinical success, also in the long term, at 6 months and 1 year. We don't have a lot of studies going below 1 year or 1 year and a half. It becomes rare. Here you have an image on the left of the technique, performed the US RFI, and on the right you have the wall lesion with some bubbles inside related to this necrosis of almost 100 degrees when we are doing this therapy. And again, in a recent study already presented before, the adverse event rate with 11 studies considered, so a meta-analysis, was 20%. But the severe adverse events were 0.9%. So in real life, the severe events are not so common, and probably this is most related to acute pancreatitis. There are always, as in all studies related to the US therapies, the abdominal pain, but this is most related to acute pancreatitis, and particularly in those cases with the main pancreatic duct very near to the lesion. So some technical points important to consider are maybe that multiple overlapping sessions can be necessary, and particularly in difficult lesions with difficult morphology or big ones about 2 centimeters. We know that 30% of these patients will be needing a second session. That's something we have seen during the follow-up studies, and antibiotic and also anti-inflammatory drugs can be necessary, even if a retreatment can be discussed also based on the symptoms relapse. Only a small points related to the follow-up, because this is a very, very important outcome, not really understood or not really analyzed in a lot of different series, analyzing only 6 months or 3 months or mostly 1 year. And at this moment, probably clinical and radiological examinations will be interesting to have, not really at 1 year, but farther away. and the modalities of this follow-up should be also considered, because we are analyzing a very heterogeneous group of patients presenting with non-functional, functional PNETs, and cystic lesions, or even metastases, as we have already seen. Finally, as we can conclude that few data on the follow-up we have in the most observational studies, and so probably we'll be needing to perform randomized fashion studies to have more solid evidence data. Thank you.
Kike, thank you very much for your presentation. I have one question and one consideration. How do you, what do you mean several events, adverse events, moderate adverse events, and adverse events? What I mean is in surgery we have a classification of complications, which is based from 1 to 5. 5 is mortality, 1 is, I don't know, pain of the abdomen, for example, or pulmonary complication. And when you say adverse events in severe fashion, what do you mean?
Yeah, this is a very good question. The problem usually we have is that we are sometimes comparing single series of RFI, single series of surgery. So we are comparing like pancreatic fistula as one of the main complications of surgery compared to acute pancreatitis of the radiofrequency treatment. And also the classifications, as you have pointed out, sometimes in the surgical group we have the EG classification, and we are using sometimes the AGRI classification. So it's quite difficult to compare from both sides. So both sides. In the RFI treatment is mostly the acute pancreatitis that can be really a severe complication. In our experience, what we have also pointed out is that it's important to understand not surgery as a single thing, but which kind of surgery will be done depending on the location of the lesion, because this will be impacting also the possibility of fistula or the possibility of complication from this side. And in the same line that the proximity of the pancreatic duct is probably related to the complications from the endoscopic therapy side.
Thank you. And the other consideration is, I do agree with you that in functional pancreatic neuroendocrine tumor less than 2 centimeters, an RFA is a good treatment, and I think that in the near future will become the gold standard. I do not really think that for patients with non-functional pancreatic neuroendocrine tumor less than 2 centimeters, an RFA is will become the gold standard, because nowadays we are treating conservatively that patient, so we only do follow-up for these patients. So comparing RFA is a procedure which has complications with conservative treatment. I don't think that this will be the gold standard in the next.
I fully agree with you. It's true that the way of the therapeutic algorithm in the different centers is extremely different, as you know, and I think we have been moving more forward to the patient perspective, and sometimes patient has also a word to say about which treatment will be deciding, and not only from our side. So I think this will be also an interesting perspective for the future. But for sure, most evidence and most solid evidence in this setting is for symptomatic insulinoma. I fully agree.
Thank you very much.
There is
Any
a question
question?
here, Matteo.
Thank you, Enrique. I have a lot of questions for you because it's a very open field, and 3. Okay. Okay. The first one is: if the lesion is at a distance lower than 1 millimeter, do you refuse to perform the RFA, or do you perform a previous ERCP? This is the first one. The second one is, do you always set the machine at 50 watts, or you choose the power depending on some factors that I don't know? And the third one is, do you perform a CT scan immediately after, 2 or 3 days after the procedure, to see if you need another session, or you expect, or you wait for the 6-month follow-up?
Okay, so we'll try to answer every question. So the first one, if the lesion is very related or close to the main pancreatic duct, I will balance the benefits and the risks. And for sure, for me, will be very important the type of surgery that can be undergone if we are deciding the surgical arm. As if the lesion typically is in the head of the pancreas, so we are discussing about Whipple, probably would not be the same as is the lesion is located in the distal end of the pancreas, and so surgery is not at all the same. And again, this is a discussion, and this is very important to understand, where the gastroenterology is one of the persons discussing, but we have also the surgical team, the radiological team deciding. So this is a complex decision, and again, patient also has a word to say. But for me, this is not a complete contraindication. It's also important to know if the pancreatic duct is very dilated or not very dilated, and you have some parenchyma in between, because sometimes there is some atrophy or chronic pancreatitis, and you don't have a lot of pancreatic parenchyma in between, and so this can be also impacting the adverse event rate. I am not performing a CT scan systematically in these cases. I think it's better to have somehow a systematic way of proceeding, because to understand if there is a complete necrosis of the lesion, I think will be better to have 3 months or 6 months examination. We are almost never in a hurry to have the CT scan or the radiology very, very quick. And the second question was about... Sorry? Power. Yeah, well, in the literature, most of studies are using 50. So it makes sense to be using 50. The question will be more for cystic lesions and for relapse, for those lesions who have relapsed in the first follow-up. So at this point, some groups are using less power. But in my experience, I think the best will be to follow the evidence we have, and so to recommend 50 watt.
Okay, I think, thank you, Enrique. We can move.
And I can invite Dr. Palumbo on stage, a radiologist from our radiology department, for the next discussion. This last session is going to be about reviewing video abstracts that we received, and it's called Expecting, Respecting, Inspecting, and Correcting Complications of EUS. This is a as you know, EUS this year is regards EUS complications, so this is an opening session to the real Congress, and we are very eager to listen to the complications our submitters had, and we would like to discuss it openly all together. So leave the stage to you guys.
Okay. So welcome, Diego, and we would like to introduce Dr. Aversano Alessandro, hopes biliary drainage when the stents go on strike. Please also introduce yourself, and we will try to make this round table.
Where is the... Okay. Hello everyone, I'm Alessandro, I'm a gastroenterologist from Udine, and I'm happy to be here today, and I'd like to share our clinical case, and it talks about a 78-year-old woman, and she was admitted to our emergency department for jaundice, fever, and abdominal pain. We decided to perform an abdominal ultrasound that showed MPD with a big dilatation until 30 millimeters, and so we started the antibiotic therapy. So the next is not a video, okay? And we performed abdominal and chest CT that showed a picture suggests to lung metastasis, and a picture of IPMN main duct degenerated. So it's okay, sorry. And so we decided to perform US FMB. And during the procedure, we have a complication, arterial bleeding, and we successfully treated with mechanical hemostasis. After all, we perform ERCP, and it shows a papilla Meyer with a prominent lumpy caruncle, and the papilla had a fisheye appearance. And we perform a lot of attempts to incannulate the papilla, but unfortunately after septotomy and precut we failed. Most probably because the CBD was heavily dislocated, and so we decided to perform echoendoscopic biliary drainage. As you can see in the first video, we released the internal flange in CBD, inside the CBD, correctly. And then in the second video, we can see the release of the external flange. But it had a leakage of only mucous material, and in the day after, the patient had the progressive clinical laboratory deterioration. So the procedure was failed again. So we decided to refer our patient from radiology department, and the patient underwent percutaneous transhepatic biliary drainage, and after 2 attempts, the condition of the patient was worsened, and so these procedures was failed. In conclusion, we did different type of biliary drainage, but every failed, and the patient had a multi-organ failure. She was took in an intensive care unit, and in some days her condition was worsened, and until the death. So, what would you do in these tricky cases? Thank you.
That's interesting. I don't know if you want to start to comment. I don't know, Diego, if you have any comment on this. I have first a question for you, and yes, then we can maybe start to discuss. Have you repeated an imaging after your first LAMS release? So when things are getting strange, probably performing an image is something I would do now to yes, see if there is air inside the bile duct, or so if anything, I mean, the procedure was technically okay, but there's any other explanation for this?
For us, it's a technical right procedures, but maybe in hindsight we can try to use RX and contrast to check the right position of the lamps.
I agree with Giuseppe that an imaging, me as a radiologist, yes, I would think about cross-sectional imaging, some CT scan to assess free air, to assess the positioning. But I have a question. Why do you refer to about the percutaneous biliary drainage 2 attempts? What do you mean with 2 attempts? The first was unsuccessful?
Yes, the radiologist tried to do the procedure 2 times, because the first was failed, and so after in few days they repeated the procedure in another site.
Okay.
And this was due according to your opinion, because the bile duct were not dilated anymore, because the lumps was okay? I mean, what the radiologist told to you, there's not enough dilation of the biliary tree. What was the reason why he felt, unsure about the drainage?
I don't know very well,
Okay,
but if we can see again the CT, maybe we see a fistula between choledochus and CBD and MPD, maybe. And so the mucus go out for the CBD.
So, okay, so that's the explanation, is that you have the fear of having punctured and drained the pancreatic duct, not the biliary duct.
In our opinion, we are in the right site, and we punctured the CBD and not MPD.
Yes, because following with this in this line, it's true that sometimes also in my experience when you have cystic solid lesions with huge size, it's quite difficult sometimes to identify the bile duct. It's quite difficult. You have a multilocular lesions, and usually the bile duct is completely compressed, and it's not so easy. So in my experience, what I try to do, if you go for the CBD axis, if no, the pathicogastric axis or rendezvous will be okay, but if you are going to the CBD axis, maybe I will try to follow the CBD from the ileum. So to turn completely left with my endoscopic ultrasound in the anterior face of the bulb to check the bile duct from the ileum. And at this point, I can follow, I can be sure that I am correctly placed in the CBD, because if not, I have already seen cases, very similar ones, and sometimes it's not easy to be sure if you are in the correct place or not.
Thank you.
But if I understood it correctly, the problem was that there were a fistula between the CBD and the pancreatic duct because of the degenerated IPM in. And don't you think so? There was a fistula between the CBD and the main duct. This was because a thick mucus came through the lumps. If you were in the right, if you were in the CBD, this is because you had a fistula.
Yes, it's not a fistula secondary to the positionment of lumps, but is a fistula. It's already present in the case. In fact,
yes, this is because there was a degenerated IPMN and it happens sometimes. And I think that the problem was that the drainages were not working very well, because you had the radiological drainage, you had the lumps drainage, but they were not working because of the thick mucus
I think the lumps didn't work because it's stacked of mucus.
Yes, maybe. Yes. I wanted to propose maybe that a SEMS, a biliary stem that could seal this fistula between the CBD and the main duct could help to seal this fistula, and then you won't have this mucus anymore coming out of the main pancreatic duct, maybe.
Yeah, just a small comment. I'm not sure that you can assess that you are inside the bile duct just by seeing bile, because I don't know what's your experience, but sometimes I see some whitish stuff coming out from my lumps, and you see, okay, but this is not bile, and then you go for contrast or just inject some air through the lumps, and that is perfectly inside. So a jaundice, a long-lasting jaundice, can appear some weird when you drain the bile duct. I don't know what's your experience. It's not always green. It's not always.
Yes, but I think that in this specific case, with degenerated IPM that you are seeing the mucus coming through the papilla, it could be an explanation. But yeah, we didn't saw the fistula, so I'm not sure. Also,
I have a question from the app that says, when considering a difficult cannulation through ERCP, what should be the level of experience of the endoscopist saying, define that the cannulation is difficult. In my opinion, I mean, we do have standards to define a difficult cannulation depending on the number of attempts and the time you spend on attempting. But actually, I want to turn this question to the discussants in when do you decide to stop attempting ERCP cannulation and switch to EUS drainage? 30 minutes, 40 minutes, 1 hour?
Maybe it's the time and the ancillar endoscopic step to reach the papilla, like sphincterotomy or precut. But if this procedure failed, maybe it's very difficult to encannulate the papilla.
Yeah, I think overall it's very important to understand the indication. So I will persist even more in ERCP if I am facing a biliary stone, for example, because I don't want to move to very quickly sometimes to US guided therapies. On the contrary, you know yourself, if you are facing a malignant tumor and you see at the beginning the papilla is quite difficult, if you have some experience, you can predict that you will be in troubles very quickly. So at this moment, maybe it will be better to pass very quickly to early endoscopic ultrasound guided therapies. No? And afterwards, in the same way, if you have performed previous endoscopic ultrasound, for example, in my experience, sometimes I do endoscopic ultrasound for having my US FNB, and I see the CBD 9 millimeters. Okay, and not very dilated, the anthropathic duct. Say, okay, so I will persist in ERCP. I will persist because I know this will be very difficult. If my CBD is a huge one, maybe I will say, okay, I will maybe move very early in my algorithm.
Yeah, totally agree. Probably personalizing is the best option, even because you are managing all the techniques, all the different techniques that Belen has explained to us. You are performing your EUS, you are performing your ERCP, so you can decide in each case whenever you feel safer to switch. I think we should move on, I guess. Thank you. Thank you, Alessandro.
So the next presentation will be complete buried lamps, cutting the wall to release the stent by Dr. Piñata Luca.
Good afternoon. My name is Piñata Luca. I work in the gastroenterology and digestive endoscopy unit of ASST Cremona, and I'm here to present this case of complete buried lamps. I can stop the presentation in some way? Okay. This is a video. This is a case of 65-year-old male with a history of severe acute on chronic pancreatitis. And sorry, I would like to stop the video. Maybe, okay. This patient presented with infected pseudocyst of the pancreatic neck and was referred for this reason for an endoscopic ultrasound-guided transgastric drainage. So we placed 10 millimeters lumen opposing metal stent and hot Axios from Boston Scientific to realize a cystogastrostomy on the posterior wall of the gastric body. After the procedure, there was a gradual resolution of symptoms and sepsis, and also the computed tomography showed a reduction of the volume of the pseudocyst. Then we have done an endoscopic control to remove the stent 5 weeks later. And we found this situation. We used a video gastroscope ultrasound of Pentax to also see the ultrasonography image of the pseudocyst, and we found the buried lumen opposing metal stent inside of the gastric wall with overgrowing mucosa and lit a small cystogastric fistula. Then we tried with the foreign body forceps to mobilize the lumen opposing metal stent, but we weren't able to do it because of the tenaciously adhering tissue on the proximal flange of the stent. We can see in these images that we weren't able to grasp the proximal flange. And so we started to think what could be the best strategy to manage this complication. The ultimate goal of this procedure was to remove the stent. So we thought about the stenting stent technique, but was not cost effective, and also in the idea to remove the stent, we thought about inseeding the surrounding mucosa, the overgrowth mucosa, with a pre-cut needle knife. This was the strategy we opted for. Now we'll see we have made 3 incisions on the overgrowing mucosa to expose the proximal flange and then mobilize and retrieve the stent with the rat-tooth forceps. This is a relatively rare complication, the baried lumen metal stent, and different strategies in case series and case report are adopted. Also the argon plasma coagulation and also the dilation of the fistula of the lumen metal stent. In this case, we succeeded only doing a mucosal incision and retrieving the stent from the proximal flange, because it's described as safer, the retrieve grasping the distal flange, but in this case we weren't able to reach it, and so but all the procedure went well without any complication. Also the post-procedural control, this is the last incision, and then the rat forceps that retrieves the stent. We drag it out from the mouth. Yes, in this case, no bleeding, no other complications. Also the computed tomography that we performed 4 days after the procedure hasn't shown problems. Also, to use a guide wire through the pseudocyst to the fistula, we thought about it, but there was a small residual pseudocyst, so it was a strategy that we thought it would be more complicated. So this is the moment in which we remove the stent, and then we will see the endoscopic control. A little bit of bleeding, but self-limiting, and no other problems. Yes, this is the end of the procedure, and everything went well. At the end of the presentation, I would like to thank the course directors for the opportunity to show this video case report of our endoscopy unit. Thank you.
Before starting the discussion, I'd like to invite on stage also Dr. Ligresti, who's part of the discussants, but I forgot to call him. Apologize.
I have 2 questions for you.
Yes.
First is how long, what was the interval between the procedure and your revision? So this was a pre-planned revision, a scheduled revision?
A scheduled revision to remove the stent. 5 weeks later, the system
5 weeks?
5 weeks, yes.
Okay.
5 weeks
so
later,
not so much, huh? It's,
not so much, yes.
Yeah.
In literature,
I would have expected a longer.
The cutoff is 6 weeks to increase the risk of buried stent. So we were also before.
By reviewing the images of the previous procedure, have you found, maybe, I don't know, as a risk factor, a thickened wall of the collection or the stomach?
Thicker than the usual, yes, from the body of the stomach. That was the posterior wall, and yes, we revised the image.
After reviewing the video, of course, you have not, you cannot foreseen that, but after reviewing the video, would you have probably chosen a longer lens to drain
maybe a longer
this collection? Thank you.
Also, the opportunity to put a coaxial plastic stent to maintain the stent patency, but in literature is not well defined if it's really protective from buried lamb syndrome or not. It's not clear, but maybe next time we will think about it.
Yeah, I think it's interesting the guide wire through the lamps when you are facing this kind of complication, and particularly in intraoperative complications. Here the lamps was buried, but sometimes when you are like manipulating the lamps with biopsy forceps, you can push it and have even a bigger fistula. Another option is like the ERCP, stent in stent, and removing a second time, if you have enough space. If you have no space, there is
In this
no
case,
possibility.
we don't have a lot of space.
SEMS in SEMS, take it with even a pigtail and waiting for 1 month or a couple of weeks could be also possible. And in my experience, when I have not a lot of buried lamps, but sometimes rather than pulling back with the biopsy forces, I try to torque the scope to have like a circle, and so to change the stent moving around and disimpact the stent to take it out. This can also be useful. At the same time, I have also seen other reports performing even dilation of the stent to have afterwards more power to take it out.
Okay.
There is no more questions from the audience.
Okay, thank you.
Thank you.
Okay, so we'll move on, and now the presentation is from Lucio Carrozza, complete intraperitoneal mal-deployment of a lumen-opposing metal stent during EUS-guided gastroenteral anastomosis for malignant gastric outlet obstruction. Rescue retrieval with peritoneoscopy through natural orifice transluminal endoscopic surgery.
Hello, everybody. I'm very happy to participate here. Thank you very much. And I'm Lucio Carrozza, and I work in Palermo at ISMET. This is my case. A 75-year-old male suffered malignant gastric outlet obstruction, was referred to our institute to perform IOSGEA because there is unfit for surgery. We perform IOSGEA with a single balloon and the freehand technique. This is the neoplastic tissue in the duodenal bulb. This is the picture of the single balloon catheter across the stenosis. We perform IOSGEA, but after the insertion of the cautery tip in the intestinal loop, there is a mal-deployment of the distal flange. You can see the incomplete opening of the distal flange due to incorrect positioning. And after, there is another complication, mal-deployment of the proximal flange, the lens is totally intraperitoneal in this case. After multidisciplinary collegial board, intraoperative, we decided to perform another attempt of EOSGEA and retrieval abdominal lamps with nodes. Second attempt of GEA. This is the cautery tip go in the intestinal loop, correct deployment of the distal flange, and deployment of the proximal flange. This is the contrast injection of the intestinal loop. Now this is the endoscopic view of the iatrogenic hole. We now decide to dilate this hole with the balloon up 18 millimeters and go with the gastroscope, operative gastroscope into the peritoneum, and with endoscopic and radiological help, we see the lamps, intraperitoneal lamps. And now we retry this with foreign body forceps. We pull gently, very gently. through the intestinal, through the gastric wall defects. The lumps go up. After the procedure, we close the iatrogenic hole with 3 metallic clips. After, we perform a CT scan that with the oral contrast that show the regular flow through the GIA and no extraluminal diffusion. A low amount of CO2 in the abdomen, but the patient is totally asymptomatic and this is reabsorbed after 24 hours. The patient was discharged after 48 hours with while feeding with the soft solid diet and no late another complication at 4 months of follow-up, and the patient start chemotherapy. Thank you.
Thank you, Lucio. First of all, you are crazy, man. Second, you don't need surgeon anymore, so I can go home. And no, I mean, this is like a type 5 complication because it's not type 1, not type 4. It's like a type 5.
A lot of complication with this.
Okay. It was really nice video and also very nice rescue procedure. Do you think that this kind of complication might happen frequently, regardless your, I mean, your learning curve, or is very associated with your learning curve?
This, the learning curve of the US therapeutic US is very tricky, and we have to work in the hospital with high volume center to see this procedure and after to make this procedure. And I think it's very important to watch a lot of US therapeutic and after to make it.
Just to bring some data into this discussion, our American friends had published a series on misdeployment of lumps, and actually they called this one type 3 misdeployment, so intraperitoneal dislodgement of the lumps, and it was the rarer of most ESGE complication, because usually misdeployment, maybe we can see some other cases later, is just the distal flange not going inside the loop, the most frequent one, but this is one of the rare complications. Yeah. 2%.
I think following this line, when you are performing the freehand technique with direct perforation with the hot axial system or whatever the lamps you are using, it's quite rare to have the jejunal perforation and the misdeployment in the peritoneum. Usually, if you have perforated the jejunum, you are in. So in this case, for example, when I was looking at the video, I think, I'm not sure you have a jejunal perforation. I think you were in between in the space. There isn't jejunal perforation. No. You were in between. And this is something very important.
It's totally
because
intraperitoneal.
Yeah, this is most frequent when you are using the wire-guided technique, but not the freehand one. The only point I don't really understand is why performing the Rido US gastroenteroanastomosis before nodes. Because this is important. In my experience, for example, if I am facing this very difficult situation, so there is no one single answer, but one can argue that if you are doing nodes, you can mobilize the new gastroenteroanastomosis and have another complication later.
We prefer to take another attempt because the intestinal defect, the stomach defect, the muscle of the stomach after the puncture was close the wall defect. And we work with CO2, and there is the patient was stable, and we think that is to complete one stage of we complete FGA, and after perform a retrieval lens.
Okay. If I can add a note to what our surgeon colleague said, is that, yeah, Lucia's right, because that patient was stable. There was no, but anyway, somehow I agree with you as well. It's, you know, it's a real-time decision, so sometimes it's not that easy, but to keep on commenting what you said, you surgeon guy, I'm a surgeon too, so dealing with this kind of stuff, and we have an amount of cases, we have quite an experience in the transmural resection of gastric lesions. So we went on purpose into the peritoneal cavity by doing a full thickness resection. So it's not that we are used to see the omentum and peritoneum, but it's not nothing that, I mean, okay. And a key point is if we have hypertense abdomen or not. So we also have the possibility to decompress the abdomen by putting a gray needle, a periumbilical needle, so that the air is flowing continuously and, you know, the stomach is not collapsing. So there are many options that we are quite used to face, and that's, you know, it's important to know.
And probably another point, a more general one, is that if you're doing so in a protected way, I mean, you're using CO2, antibiotics, the stomach is clean, actually is kind of a surgery. But the problem is that you don't be tempted to do the procedure even if the stomach is full of food, of residual food, so it's better to abort that procedure if as for example, the ward does not place the neurojejunal tube to clean the stomach, because these things can happen, and if you want to do notes, you have to be, I mean, you have a clear stomach and so on. There is a question from the audience. If you had noticed a jejunal perforation, I mean, even if the lumps was not inside, but you had gone through the jejunum, would you have started the procedure again, or in that cases you have preferred surgery because there is an hole on the jejunum?
I think that if we had a jejunal perforation, we talk with surgeon for a surgeon.
Michel Calais would not agree with you.
Okay. Yeah, you're referring to those, last year, I remember, and some other reports that are saying that you can grab with a grasping force of the perforated jejunal loop and redo procedure using the same tract. Yeah, that's not an option.
Okay, thank you very much.
Thank you.
So we have Dr. Elena Tenorio Gonzalez, 3 scenarios of Eus-guided gastrojejunostomy misdeployment.
Good afternoon. I'm Elena Tenorio, and I work at European Georges Pompidou Hospital in Paris. I have 3 cases we have to see all together. So the first case was gastric perforation without general perforation. As you can see here, as a first site, we have the space to place our lumps. But before to perforate, we should take a lateral position to avoid a vessel. So we will see as we perforate, but the catheter doesn't pass into the general loop. So there we have a poor endoscopic ultrasound view, but we cannot see the distal length of the lens catheter. So we decided to pass a guide wire, and we saw that there was no passing in the general loop. So as we had already done a gastric orifice, we decided to stay with the whole system pulled back until the gastric wall and to choose a new axis to perform our jejunal orifice. To be sure, this time we did push and pull movements to deplace the jejunal loop to see that we were in the correct position. And after perforation, you can see that now the distal flange of the lungs is in the jejunal loop. And we confirm on the fluoroscopy view and ultrasound view that we were in the correct place. In a second case, we had a gastric perforation and also a jejunal-free perforation. So the distal flange of the lungs was deployed in the peritoneum. We perforated, but we saw that we couldn't pass with the catheter into the jejunal loop. So we passed a guide wire that we could see that was passing into the jejunum, but we couldn't pass the catheter. So as we had already a gastric orifice, we deployed the lungs, and we changed over a guide wire for a gastroscope. We went with the gastroscope. We dilated the lungs until 16.5, always with the guide wire in the jejunum. And after, as you can see, the jejunal perforation, we also dilated to facilitate the passage of the new lung stent. So that after we could place correctly a second LAMS 2010 by technique stent in stent and then endoscopic and fluoroscopic guidance. And in a third scenario, we had a gastric perforation without jejunal-free perforation, and the LAMS was deployed in the peritoneum. It was confirmed after deployed the LAMS. So the guide wire went into the peritoneum. We decided to change to a gastroscope, and we saw in endoscopy view and also in fluoroscopy view that we were in front of the jejunal loop. So we decided to open it with a needle knife. And after we passed a guide wire into the jejunum by the orifice, so that we could attempt to place a new lungs over the guide wire without needing to delay, performing again a stent in a stent. And we always confirm the opacification that it was in the correct place. Thank you. That's the end.
So congratulations, Elena. There were extreme cases and very well resolved. Do you think there is a common situation or aspect in all of cases? So there were not enough distension of the bowel, or what do you think? Why was the reason for the deployment?
In the first case, with the gastric perforation, but no jejunal perforation, I think it was because of the axis, the lateral axis that we tried to do to avoid the vessel, because after we could get a very good access to place the lamps. In the other two cases, I think the second that we have the free jejunal perforation, it was not to perforate completely the jejunal loop, but in the third case, maybe it was the tension of the loop, I think.
Do you use color in your contrast? I mean, because we are used to, this is helpful sometimes to control because sometimes as you told us, you lose the US view, and then you are not sure was the catheter inside of the loop? Did I perforate the loop or not? And in these cases, when you see that the color is coming to you, you are sure that you perforated, and you know that you have to solve this or close this perforation, or you have to send the patient to the surgery. So
that's true, and that's useful. But here, both misdeployment of the lamps, we saw it during the deployment. So in that case, we deployed the distal flange, knowing that we weren't in the correct place, but to solve that after. It's true that the blue will help, but also we say that if you have nothing, you are in the peritoneum. If you have intestinal liquid or serum, you are in the correct loop. But that helps.
What we do in this case, I have shown in some of the videos in a previous presentation, is before dilating, actually, to check if through the orojejunal tube we can manage to aspirate some contrast in the stomach. Mm-hmm. Because our perception, of course this is not the truth, but our perception is that if you are not in and simply remove the lamps, you can restart the procedure without any additional escalation by removing the lamps and redoing the procedure. Conversely, if you dilate not knowing if you are inside or not, you are obliged, of course, to do notes then, and this might sometimes be an escalation for the patient in terms of complications.
You say that for all the cases or only for the first with the gastric perforation? Because I think if you have the jejunal orifice also to retire the lamps, you will also retire the lamps in that case?
The problem is sometimes you don't know if you have entered the jejunum, no? But if you have an orojejunal tube there, you can inject contrast. If you see no leak,
I understand.
Probably the hole is so small, and if you realize a correct use-guided gastrojejunostomy, nothing will happen. But this is our perception. I cannot say that this is the real.
I fully agree with you. I think this is a good message probably to give, is that when you have a gastric perforation with misdeployment, you can always take out the stent, close the defect of the gastric wall, and stop or restart again, and nothing happens. So this will be, I think, the most important to keep as take-home message. This as very, very particular cases, but in real life, if there is no jejunal perforation particularly, you can take out everything.
There is a question from the audience. There's a microphone for the audience.
Usually we are filling the jejunum with water, saline and so on, and for example you made fistulotomy to the jejunum, so does the fluid leaks to the peritoneal hole? Because we saw the jejunum was just empty and full of air, so where is the fluid came, and is it dangerous? Maybe also the question to the surgery. And if we left some fluids, like with the debris and so on, in the peritoneum cavity and give antibiotics, if it's okay, so far we saw yes. And also the question, if we, with the lamps, we just touch the jejunum, but we don't perforate, if it's possible that it will come as spontaneous perforations, like after a few days.
Can I say something about this before you? If you make an hole with an axios, with a lamps, that is an electrocutter enhanced hole. I mean, there is some tissue reactions due to the current. Probably nothing will leak just for the hole itself. I've tried that a couple of times. If you inject contrast in a hole of a misplaced lamps after removal, nothing will leak. So probably we fear those small, tiny holes more than it's necessary. But again, if you have an longitudinal tube there, you can inject contrast and see if something is going out, and if of course, that is probably the case to call the surgeon and go for surgery if there is an abundant leak. But if there is no leak, I don't think it's the simple hole or simple contact with the jejunum is an indication to abrupt the procedure.
Well, from surgical point of view, if you have liquid in the abdomen, it depends which kind of liquid you have. If you have a small amount of bile, you cannot have any problem with the patient. Or if you have lots of bile, you can have obviously pain, and then you need to do something. That is not only surgery. You can drain, you can wait, you can see. We do not think that surgery is the answer to all the complications that we have during our job. Another question is, do you think that we need to drain all the liquid that we have in the abdomen? My answer would be, it depends from how is the patient. So if the patient is stable and is not in pain, you can wait. Otherwise, you need to do it.
We have a question from the floor. That is, should notes also be an essential skill and also tool in order to be a therapeutic EUS person? What do you think? Elena and the discussants.
But to me, it's not essential, but it's true that if you perform a technique, you need to know to solve all the complications you can have. So all skills are good, but in this case, I think the most important thing is to have a surgeon at your side. You can call if there's any problem.
Yeah, I agree. I think notes is a very, very rare situation, because in most of the cases, we have already said, you have a misdeployment with the distal flange of the lamps in the peritoneum, but no jejunal perforation. And even if you have a jejunal perforation, I will guess that in most of the cases, and particularly if you redo the gastroenteral anastomosis as this is correctly done, there are no clinical consequences. So I don't think that notes should be in the armamentarium of essential skills of endoscopic ultrasound endoscopists. I will not say that. Probably the worst scenario will be to have your jejunal perforation and tract a lot your distal flange of the lamps, and so you have jejunal perforation with the cystotome and open it by the stent. So at this point, you will probably be needing to move to surgery or to nodes or something, but a small, teeny 10 French hole in the jejunum, if afterwards the patient is not eating and you have your anastomosis, not sure there will be clinical consequences. Nothing happens. Thank you. Elena, we'll move into next case, also presented by yourself. Repositioning for gastrogastric lamps after migration into the sclerotic stomach by passing a duodenoscope.
So this was a man with a bypass and a biliary stone showed in the CT scan. So at first we performed a gastrogastric anastomosis by ultrasound endoscopy, and 40 hours later we tried to pass with the duodenoscope through the lungs to perform the ERCP. At a first attempt it was not possible, so we dilated the lamps until 16.5 millimeters, and we did a second attempt, but as you see the lamps come into the excluded stomach. Now in retrovision view, you will see that the lamps is inserted in the duodenoscope. So as we were already in the excluded stomach, we decided to perform the ERCP and after resolve the migration of the lamps. So after the ERCP was completed, what we did was to pass a 0035 guide wire into the duodenum to assure the passage. And after we pulled back the duodenoscope until the gastric cavity, once there we did movements of torquing and also trying to disinsert the lumps from the duodenoscope. That's how the lumps rest in the excluded stomach. So that once it's disinserted, we can, with rat tooth forceps, take the lumps and reposition in the fistula. I would like to point out that there were no evidence of anastomose dehiscence or obvious perforation in the fistula. And after we achieved to reposition the lumps into the fistula, we saw also after under fluoroscopy view that there was no leakage of contrast into the peritoneum. In any case, at the end, that's not in the video, but we also decided to place a 7 French 7 centimeters double pigtail stent for safety, with any other complications. That's it.
Okay, very nice case. I think, Belen, do you have a question?
Well, yeah, congratulations. How long do you usually wait until, since you create the fistula, until you perform the ERCP through the stent? Was in this case so short? I think 2 days because it was cholangitis, or
exactly. Sometimes even we perform it in the same time in one shot, but usually we wait for 48 hours. And as we saw, the fistula was major. There was no problem of leakage or perforation, so we think it's safe to do it in case of overall cholangitis.
Well, and wouldn't you fix the stent with a Novesco or maybe with Apollo? If you have to go directly to the ERCP, or in...
No, we don't usually fix the lumps. We don't have lots of cases of migration. Here I think it was, we were doing 2 torquing movements, but we push a little bit, that's why it migrates. But usually you don't have that kind of problems of migration, even if it's 40 hours later.
Mm-hmm. Yeah, I think in our experience it's even more important sometimes the axis about the gastrogastric anastomosis rather than the diameter or the fixed action of the stent. Sometimes we have also been working in a study publishing that when we have a jejunogastric axis or a very proximal or very, very close to the sclerotic pylorus, somehow it's difficult to pass the duodenoscope, even if you have fixed or even if you are performing dilation. So axis, I think, is the issue. Okay. Thank you, Elena.
Thank you.
The next speaker is again Dr. Carrozza with intracholedosic bleeding after EUS FNB.
Okay, hi. No? Can play? Okay, this case is 74 years old man affected by the arterial hypertension was referred to our institute for jaundice. Is perform a CT scan. You will see the structure of the third part of the biliary duct with the dilation of the intrahepatic duct. And we decided to perform a US for FNB for the stricture, for the characterization of the stricture. You can see a hypoechoic lesion in the common bile duct with dilation of the common bile duct, and we perform FNB with 22 gauge needle. After FNB, a complication occurs. There is, you can see a intracholezogic bleeding, a hyperechoic liquid in the common bile duct, and the common bile duct was replaced with the blood. Now we decide to drain this biliary duct first with ERCP. But despite despite the precat, we don't have access to the common bile duct, and we decided to drain with the USBD. Now we perform USBD, cautery tip go into common bile duct. We release the correct, this is correct release of the distal flange. After, release the intra-channel release of the proximal flange. This time. And pull for the release of the proximal flange into the duodenal cavity. You can see after the USBD, fresh blood to then through the lamps. Histological examination was adenocarcinoma. The patient undergone a duodenopancreatectomy for poorly differentiated adenocarcinoma. In conclusion, USFNB of biliopancreatic is a safe procedure, but the management of the intracholedotic bleeding needs expertise in biliary endoscopy and feasibility of the radiological room to immediately perform ERCP or USBD. Thank you.
Can I ask you a question? Lucio, thank you very much for your presentation. I would like to ask to all the gastroenterologists that are here, who think that it is mandatory to have a biopsy in case of ampullary lesion or periampullary lesion before doing surgery?
This is not an ampullary lesion. It's a malignancy stricture of the
periampullary lesion anyway. Do you think it is mandatory to have a biopsy first?
Ah, okay. I don't understand.
This is depending on my surgeon.
Okay.
Yeah, this is the question that we usually give to you, surgeons, and most of times you say yes, you need it, or also the oncologist maybe they need it. So, what's your opinion about it?
In my opinion, considering the low risk of complication, I would have a biopsy before doing Whipple procedure. But I would like to have your opinion, because this is what we think, and sometimes we are in argue with the endoscopy. So why you want to do a biopsy if this is a clear lesion that you need to take out?
In our experience, sometimes some cases with a very, very suspicious MRI and CT scan and repeated negative biopsies. So one moment we say, okay, it's very clear from the radiological examination, and we have a first or even a second, this is rare, but negative biopsy. At this moment, we can maybe argue to go directly for surgery, but in real life, in my setting, it's not very common to go without biopsies.
Okay.
Lucio, is there any issue to perform choledochordodenostomy as a bridge to surgery procedure, as it happened?
Yes, it's a good procedure for a bridge to surgery. Our surgeon was, it's okay for this procedure.
And why not to perform, why didn't you perform ERCP with SEMS stenting instead of USBD?
You can repeat.
They were not able, okay.
My question was, did the patient require biliary drainage, or this was just done on the purpose of stopping bleeding? I mean, she
no,
was
for the risk of cholangitis, for the bleeding.
Okay, so it was done on the purpose of bleeding.
With this purpose.
And did you obtain a separate consent, or did you go straight for ERCP without awakening the patient?
We go straight for ERCP.
Okay, so you had to explain after the patient that. Okay.
Okay,
thank you.
Can we move on to the next speaker? That will be again Dr. Carrozza. So
in ISMET we make a lot of complications.
A lot of complications. Yeah. So you will talk about successful multidisciplinary urgent management of a life-threatening intraprocedural bleeding after EUS-guided fine needle biopsy of a pulmonary mass. So mediastinum again.
Yeah. You can play. This case is an 82-year-old man with diagnosis of adenocarcinoma of the right colon, who was referred to our thoracic unit due to a pulmonary lesion suspected for malignancy in the left upper lobe. CT scan showed a 40 millimeters lesion on the left upper lobe, and we decided to perform IUS to distinguish the lesion from this is a primary lesion or colonic metastasis. The patient suffered by atrial fibrillation, so he was under anticoagulant therapy. He was switched to heparin more 72 hours from the USFNB. We perform USFNB. You can see the pulmonary mass was close to left subclavian artery and aortic arch. Color Doppler evaluation is important to choose the right window to perform a FNB without interposed vessels, and we perform FNB. But after FNB, at the end, the patient have fresh blood out of the mouth. We perform a gastroscopy with the frontal view scope. We see the intratracheal blood. And in this case, the patient, the saturation and the blood pressure of the patient go down. Anesthesiologist performed endotracheal intubation and vasoactive drugs for the pressure. Simultaneously, thorax surgeon perform a bronchoscopy with DM to identify and treat the site of bleeding. Now we can see the bronchoscopy. In this case, we can see a lot of fresh bloods and clots in the left main bronchus, but the site of the bleeding is not identified because probably is a bronchus, a thin bronchus peripheral, and the thoracic surgeon instillate tranexamic acids and aspirate the clots and the blood, and the saturation of the patient go up after aspiration. But unfortunately, during the ventilation, the patient developed a pneumothorax, was treated by chest drain. But the patient was stable at the end of the procedure. The patient was extubated and woke up stable, clinically stable condition without any sign of neurological or cardiological pain. And chest drainage was removed after 3 days. And the patient, this is the picture of the thorax after 9 days of procedure. Histology showed the squamous adenocarcinoma. In conclusion, FNB of intrapulmonary mass is safe, but extremely rare can bleed. And it's fundamental to have a dedicated and shared room where performing this procedure with a multidisciplinary team, include the endoscopist, anesthesiologist, bronchoscopist, and interventional radiologist and thoracic surgeon. Thank you.
Congratulations for your presentation.
Thank you.
I have 2 questions for you. The first one is, why did you prefer Eus-guided biopsy of that mass and not a CT-guided percutaneous biopsy of that mass?
In our center, we perform a lot of FNB of pulmonary lesion. There is Dr. Ligresti is a pioneer of this. And the lesion is very close to the esophagus in the left upper lobe and is easily to punch. But in this case, probably the vessel, the reality or vessel of the tumor bleed into the bronchus.
And the other one was that in the moment that the bleeding starts, do you go direct to the thoracic surgeon for the bronchoscopy and so on? Did you consider also an imaging at that point? Because you can also have a bleeding from other sides from that of
we identify correctly the blood who came out from the trachea with the scope, and we treat that. But the patient, you can see the RX of the thorax, and serially performed for watch the evolution of this complication.
Okay, thank you.
I also have a question for you, Lucio. What do you think was the problem in this case? Was a problem that was a bleeding starting from the fact that you didn't have probably a proper window to perform the biopsy, or was a problem that you performed the biopsies on the pulmonary mass and probably was the mass that was bleeding?
I think that a window is correct, but the tumor and the vessel of the tumor is very frail and can bleed. And this is a complication into the for this procedure, inside this procedure.
Okay, so if there is no other question, so we will declare the winner of this session, and you can stay here, Lucio, because we have an ex aequo between 2 of your abstracts actually, so you are the winner of this session.
We don't have a medal for you, so
no?
you will come next year to the next gen and to the hands-on session.
Okay, so I guess it's time to close the day for today. I hope it was an exciting day for all of you and that we all go back home with some learning, some beginning of learning, and in the following 2 days of Euro-Eus we will talk more, see lots of live cases, and hopefully it will be as interesting as today. I would like to thank all the discussants and all the participants and speakers from today's session, and I want to say hi also to all the people following us online, because this year, for the first year, we had the possibility to go on streaming and follow this Congress online. Thank you, everyone, and Matteo, would you like to say something more?
I cannot agree more with you, and I also would like to thank you so much, you, all the participants, all the discussants, and I hope to see you again next year, and I hope to see you all also tomorrow and the day after tomorrow, because it's going to be a very cool Congress.
Thank you, and see you tomorrow. Enjoy Milan.